Welcome, everyone, to our Integrated Care Board meeting in July. A few things I want to do as an introduction. I think I'll just set the scene in terms of some of the apologies and who's deputising in that first of all, if I may, and then I'll do my sort of intro and welcome. But Steve Williamson is on holiday. We have Ella. Welcome today. Debbie's on holiday. We've got Adi. Welcome to you. Chris is on holiday. We've got John, but we'll come back to do some introductions later on. Simon Gitters Davies is on holiday, but we've got Simon here. Welcome. And we've got Smitesh, which I'll come to in a second. So I think that's, yeah. And Kate has sent her apologies because Kate's got COVID. So in terms of the introduction, there's quite a number of people who are actually on holiday, which is fine. As I was saying before we started, I couldn't quite plan for... one of our colleagues actually has pneumonia. Quite a few of our colleagues have actually got COVID. Kate's got COVID. I can see Mary's on the call. Thank you so much, Mary, for coming in today. I know you've got that as well. So I think we've got our deputies in place, and they will take the full role of their statutory directors in terms of this position. So let me kick off by doing a few introductions as well. So in the room, we've got Smitesh, welcome. Smitesh has formally taken up the statutory role on our board as the Primary Care and Medical Services Partner Member. Would you like to say a little bit about yourself?
Thank you, John. Yeah, I'm really excited to be taking on this role. I'm a GP over in Liskeard at the moment, a salaried GP. I've been in Cornwall for just over 2 years now, and previously worked as a GP over in Essex and the home counties for about 12, 13 years. So I'm really looking forward to joining the board and trying to make a bit of a difference. So thank you all very much for welcoming me.
Welcome. And one of the discussions we had before you kindly wanted to sort of join us, having gone through the nomination process from your colleagues, is of course primary care is wider than general practice, and this particular role you've got is actually wider than that as well, because it's including medical services. So we have reminded each other, you and I, that your portfolio is very wide. Primary care, in this instance, we need to make sure you're covering off with colleagues from pharmacy, optometry and dentistry. And you and I will talk about quite how we ensure those big issues get raised through here in the appropriate manner. So let's do some more introductions. On the screen, actually I'll go to, we've got Steve. Steve is the Chief Executive of the Devon Integrated Care Board. So do please introduce yourself and maybe say a bit about yourself, Steve.
Yeah, thanks, John. Great to be here. Apologies, firstly, for not having made one previously. I'm now 5 months in, so starting to find my way around a bit more. So I'm really delighted to be here today and looking forward to the joint working that I know is already underway between our two areas and needs to go further. So thank you, John. Great to be here.
And welcome. John Clark in the room. You're standing in for Chris, so please tell us a bit about yourself.
Morning, Deputy Chief Medical Officer, been here for just over 3 months now. I'm part-time with the ICB. It's 3 days a week and 2 days a week at Trelesk as a consultant gynecologist. I'm very happy to be here.
Thank you very much. And Ella, I appreciate that you're actually standing in for Steve. I think the conversation we need to have with yourself and Steve is going forward. We need to make sure that the deputy is representing the NHS provider partners. Yep. And less about the RCHT in the room, so we can form
my understanding of being here today. Obviously.
Yeah, I just think we just need to make sure that the nomination of who that is formalised. So we'll just go through that process post here. And I did forget to actually say apologies from Molly, our company secretary. For those who don't know, Molly was involved in a car crash last week, and she let me know that she's actually had quite a serious incident physically as a result of that. So it was a little bit more than a dent. So we wish Molly all the very best. So like I say, the best laid plans and all of that. Okay, so let me just do a little bit of an intro then. Mary.
Yeah, thanks very much, John. Just wanted to reinforce what you said. We're really clear that Ella is here representing all of the providers, and the reason I'm here is for the RCHT part.
Exactly. Thank you. So a broader introduction, if I may, for the day. So does it feel like we're just over 2 years old? Did you get candles and blow them out and say, happy birthday, ICB? Because on the 1st of July, it was 2 years, can you believe? Hasn't that flown by? So the reason why I just wanted to remind us is I think we've come a long way in 2 years. I think we've got a collegiate group of people. It's not always easy to have difficult conversations, but I think we now are able to have those. And I don't think today will be any different. As we look towards some of the in-year issues and as we start to plan for next year and the future, I think there are going to have to be some really tough conversations about how we're doing, what we expect, and the change that we expect. So increasingly what you'll start to see in the board papers will be the challenge to all our executive colleagues to ensure they focus about in-year, next year, and I'm going to say 5 years while it still sticks at a 5-year joint forward plan. Because we've got to start thinking about the decisions we need to take, not just to achieve our performance in year and now, but also what are the key decisions that we need to start taking now that will influence next year and the future. On the agenda pack, you'll see, and it's quite a crammed agenda today, but you'll see a paper on primary care and community. And I think there's a discussion we need to have about the definition of primary care. I think there is a discussion to be had about whether we're ready for the proposals. And that links nicely, which is why the agenda has been pulled together this way, about what are the decisions to support primary care and community services that are beyond just the high level supporting, and what does that mean in terms of channel shift? What does it mean in terms of performance? What does it mean in terms of funding or people or whatever it is? Because it's easy to sign up to a principle. It's often much harder to actually sign up to the implications of it. So part of the journey that we're trying to have here is nothing to come as a shock to anybody as we go through the next 6 to 9 months in terms of some of the big heavy lifting ticket items that we're trying to cover off. So as always, please be frank and please be concise. We've got a pretty busy schedule today. So that's my introduction. A little bit different today, colleagues. When we get to lunch, here's how we're going to try and do it. So for those colleagues on the, bearing in mind part 1 public session is going to straddle lunch, what I'm going to do is, with respect, I'm going to ask colleagues to stay in the room. Those members of the public, I'm going to ask, could they please move into the next room? And then for those colleagues who are on the call, would you mind moving to the part 2 link immediately? Because then what we're going to do is we're going to bring in the executive group's top team just to do some informal hellos and whatever else for a short period of time. And then that'll be for about half an hour. Then we'll move to a half an hour. You can all mingle and do use that time to talk to our new colleagues about that, because they're putting faces and names and meeting and say, what do you do, is pretty important as we go into joining up our thinking. And then we'll come back and continue part 1. And then colleagues on the call, if you could revert back to part 1. So I know that's a bit laboursome, but it's the best way I could think of doing it with people and colleagues who are remotely. Okay, everybody happy if we move on? Yeah? Okay, so let's move on to declarations of interest. And I said, as Molly's not with us, we've got Jess taking the minutes. And I assume you're on the call. Yes, I can see you, Jess, you're on the minutes. And Tracy, I've asked you to help us make sure we take cognizance of some really key decisions we want to make. So on declarations of interest, anything more to declare? No? Okay. Approval of the minutes for the 13th of June. You happy for me to sign those for accuracy? Rachel?
Note that John Siddell's name's spelt wrong through the minutes, just to amend that.
Thank you.
Thanks.
And Adi, yes, I knew your hand would go up, but Adi, why don't you say so?
You've got we've sent the tweaks through, really minor tweaks, but on straight after the mental health partner update, just in terms of rather than CFTR to become a research active organisation, as illustrated by last month's deep dive, CFTR are becoming an active research active organisation, and then further down it refers to loss of capacity at Riverside. I think we just need to be really clear that that's CAM's capacity, for which we are providing mutual aid. I think it's just too quite.
Yeah, happy to make those changes. I've seen those. I'm happy with those. Everybody else's. Okay, I'm going to sign the minutes. That's fine. So I can turn now to Jess and just go through the actions. What ones can we close down, Jess, please?
Yeah, thank you. So within the action grid that's appended to the minutes, there are a number of actions that are highlighted for closure this month. Those are highlighted in grey. There's approximately 11 of those. So we've got a number that are being closed off by items on the agenda today. In addition to that, we've got a item around the wiring diagram for clinical reference groups, and that should be coming out to board members by email shortly after the meeting. I've received that, so that action is flagged for closure. And we will continue to send the action grid around to board members, participants and attendees and seek updates on those actions that haven't been flagged for closure this month. There are a number that should be being closed in September according to their target dates. Thank you. Thank you.
Okay, any other observations? Tracy, happy?
Yeah, there are two, one at the bottom of the first page and then one at the top of the second page, which both said they were going to SEG at the end of June.
Yep.
So if we get confirmation that they are from Susan, we could close those two down as well.
Yep.
Yeah.
Okay, let's move on from that then. We move on to the health and care vignettes. So you all had a good chance to look at them. So for our new colleagues, Smitish, I don't know if you've spotted this, but there are 5 vignettes that the team do offline. Everybody reads them, views them in advance, and then we have a brief discussion. So we don't present them. So on the ones that are there, any points anyone would like to make? So yes, Nick.
So I would just like to say the one of Nuki Orchard, I think our communications director jumping up and saying whoop at the end was enlightening and fabulous to see. I just thought what a really genuinely lovely, all joking aside, to see people out and about and actually getting literally mucked in, and the farming I thought was fantastic. So yeah, Lucy, well done for not editing that out, but it was fantastic bit of real life. Thank you.
I see you smiling. I see you smiling at these things, isn't it? And shaking your head too.
About health creation prevention channel shift. So Nuki Orchard is one of our test and learn sites around good fresh food and the impact that can have on things like diabetes and long-term conditions. So it's a really good one to be watching.
Rachel?
Thank you. I mean, I think all of the vignettes are fantastic, and they really show that strength of community support for people's well-being, which is the sort of contrast of some of the things we talk about here, but is really underpinning our society in keeping people well. So really good to see. And then again, on the food conversation, we support Sustainable Food Cornwall, which brings together a lot of the growers, and Nuki Orchards just being one community growing scheme in Cornwall. I think there's a lot of opportunity around that. And I'm also attending a food conversation at the weekend. So down in Penzance, the Food, Farming and Countryside Commission are coming to talk to people living in Cornwall about what food means to them and in terms of growing and community food activity. So I'll be attending on behalf of Cornwall for that.
Thank you. Ella?
Yeah, also on the Nuki Orchards vignette, it reminded me of a initiative we had within the acute hospital around called Apples and Pears. It might have been Susan during your time. And speaking to the team there, it had huge success in terms of with enabled us to discharge follow-ups for fatty liver disease. So there's already some really great examples, and it just made me think when we're doing our planning, Tracy, if for future years we can plan some of these initiatives into our pathways, it would be really great to see.
Thank you. Neil?
No apologies for linking in with the green prescribing and Nuki Orchard, because it's such a fundamental prevention issue. I think I just want to say that the ICA committee heard the other day that this principle, this way of working is spreading across the county pretty rapidly. It's to be endorsed, and it must be a major part of what we do. And I'll say it because it's important that people know, it's not just we think that's working. The evidence for pre-diabetes and the people being helped through Nuki Orchard with mentoring and this approach is that people are improving their HbA1c levels and not needing prescribing additional medication. So I think it's really important to note that here.
Okay. Susan?
I'd just like to say the vignette around the research for stroke is just a huge reminder of the importance and the power of research, and how seeing it being embraced in this way, we need to do more of that.
for our longer term prevention as well as faster recovery. So it was really, really great piece.
Martin?
I think I was the same, and it made me wonder, I wasn't sure whether we had an annual sort of research update, stroke review on the agenda at some stage, because it'd be good as an ICB just to keep an eye on, how our research develops, given the possibility of improving healthcare in Cornwall and nationally, really.
And I wanted to focus on the Penley Family Project. It's one that we funded through the ICB's Health Improvement Fund. Again, it's one of those really beautiful examples of small organisations at the grassroots, utilising volunteers, creating connection, support. It's the kind of thing where £5,000, £10,000 makes an enormous difference to local communities. And I just think it's something that we need to keep really high up on our agenda as we're thinking about channel shift, that's not just about big pieces of work around diabetes prevention, but actually we do include that kind of really small grassroots funding, because that's making a huge difference locally.
Just building on Emma's point, I think not just how far the money goes, but the productivity gained, particularly in the voluntary sector, with a small amount, because a lot of what they do is obviously through volunteers or through support from other charities. And you can see it in how they've made use of very small grants behind those vignettes. So it only sort of stretches the case further that in constrictive times financially, there's a huge opportunity here if we can create that channel shift. And the examples there are an example of what's already been done.
Sure. And I'm sure we do some of this already, but I had the joy of spending a couple of days in Gloucestershire with some of the chairs and chief executives across the South West region and with regional offices. And it was fascinating to actually see some of the things they're doing there, where the small amounts of the commissioner's funding towards general practice in that instance, how they then worked with local communities, etc., to do things. It's amazing how very small amounts of money used wisely can actually generate huge, not just immediate, but the point they were making was sustainable answers. Okay. So one of the themes that sort of came out for me, I was watching, bearing in mind our agenda was set before the general election, and our strategies were too. I think it's interesting to sort of set some of the things that I've started to see out of government in terms of these vignettes. I think help this, which is the gravity of shift between how do we get things done less in acute and more in the community. I think there's something about that we are doing. We've got to think more about how we do that, how we move away from being an NHS service that actually is set up to sort the sick to actually becoming how we are preventative in that. And I think that sort of starts to leap out. And this is part of the agenda deliberately today when we set this a few weeks ago, which is looking towards what we're going to do in 25, 26. And by the time we come back, if you look at the agenda, some of the financial planning that we've got is we need to get to a place like October, and we've already had the tough debate about what we're going to do in 25, 26, because then people can actually get their minds around with 6 months' notice what are the sorts of things that we're going to be doing and make collective decisions now that also impact Indians. That's the second thing, which is moving to a more focus on prevention, which we're all up for. I think we've just got to focus on, spiritually, we may be up for it, but how we're actually channel shifting the resources that actually go with it in a planned manner. And that'll come out in the planning cycle part of the agenda. And the third one, which is, Susan, I think where you and colleagues were picking up, was moving to increasing sort of medtech revolution and research and innovation and that kind of thing. And I know we've got John from the John Sindel I'm talking about here, focus, but I'm just wondering whether we ought to, on the future planning, Tracy, whether we ought to ask him to come back again and give us, where are we on that? Again, I hadn't heard of, is it Brave AI? Is that right? I hadn't heard of that until yesterday. And there's something for me about how is AI going to be helping us? So I know that, Tracy, I know that I've been chatting more to Molly about this, but I know you're engaged in it. Is in terms of our development days, we've got a plan for a digital away day down the track, and the States coming down the track. There's something for me about that digital one, which is again about channel shifting. It's about different ways of working. It's about AI and its implications on services and that kind of thing. So I think just having the data is one thing. Prepping for these things and having a really meaningful set of conversations, I think would be really helpful. So again, Lucy, I thought this was very thought-provoking, very helpful, and consistent with our direction of travel. Everybody happy with that? Yeah? Okay, let's move on. So I think you can take my chair's update as read. If there's any questions on it, a couple of points I'd just like to bring out. We had at the end of our last board meeting a couple of hours with Roger Klein on EDI and race and things like that. I'm still absolutely so taken by those 2 hours. And it was great to actually see Tarn, you as our workforce chair with Patrick, actually immediately take some of the stuff that came out from Roger's presentation into our workforce committee. I see we've got on the agenda some of that. I think if you could give us a strong update on where we're going on that. And as part of the regional issue on this issue, I think we need Patrick to start weaving in some of the things that we're thinking about, how we're actually really going to change the agenda on equity and race locally. So that's something we have to do together, everyone, by the way. That's not just the preserves and ICB for our 300 staff, by the way. This is much more a systemic issue I'm trying to refer to. So I thought Roger's provocative challenge to us. Also, the thing I think I ought to say here is that I notice when people like Roger is complimentary, everyone welcomes it. When Roger's actually slightly challenging, people get defensive. I think on something like this, we've got to move away from being defensive and going, have we sorted it? No. Therefore, what will we do? And I think that's what I'll be looking to your committee, which is if it isn't broken, well, fine. But if it is broken, let's not pretend we've cracked it. So I look to you on our behalf to come back on that.
Do you want us to take that up later?
Can we take it under the EDI item? All right.
Sure.
So the only other one I want to pick up is another regulatory item. Now I have to say, John, I know that Chris led the dentistry conversation, but I thought it was transformative to actually have NHS England, region, ICB and colleagues, and what was about 30 dentists together the other night, because I see we've got a dental strategy on it, but I actually felt that we probably made more progress in that session. And I think we've just got to be clearer going forward what we're doing on dentistry, on optometry, and on pharmacy than possibly we have at the moment. So if I could just ask you to think about how, either in this meeting or in future ones, we make sure that we pick up all three of those key areas. And Smitash, that's why I did my intro. There's something here about primary care and communities are, we all know this, sort of all interlinked and joined up. Is there anything else anyone wants to bring out? Because those were things I wanted to share. No, very good. So let's move on. So we've got now the Chief Executive's update. So Susan, would you mind doing Kate's?
Thank you, Chair. I will leave the paper taken as read. However, I know, speaking to Kate this morning, what she wanted me to just point out is our operating plan, delivery of our operating plan. We've created a set of slides which, through Lucy's team, explains not only to staff but to public as well what we're trying to achieve. Because I think the message Kate wanted to share today was this is the year of change, and setting those foundations are incredibly important because we've got some very big change projects coming, and already having those meetings and already starting to have the conversations that demonstrate just how big this is. So the slides set out very nicely what we're trying to do and why we're doing it. We will continue that. We've got our next planning round for next year meetings happening over the next couple of weeks. The only other thing that I'd like to point out, Chair, is we had the final element of the ICB annual assessment, which took place in June with NHS England. In summary, challenging but very positive year, and there were a number of issues that were flagged for positive information for our board. Increasing maturity, you've said that already. We're 2 years in, and that's really starting to show the commitment that we have as a system to recover our position across the system, and still having those hangovers, particularly with our waiting list from COVID, but a real effort to recovering the position. Developing novel and innovative solutions. We made mention many times in this meeting of the X-ray car. That's something that Region is picking up and is offering funding to other ICBs who are also picking this up. The work that we're doing with our community partners, Emma's described, small amounts of money make a huge difference. So for our planning rounds, being really clear about our commitment, working with our community partners is incredibly important. it's a tough year ahead. I think we all know that, and I think the agenda demonstrates that. But our commitment and our ability to work together collegiately to a vision is incredibly important, and that we leave our meetings professionally as friends, having had the difficult conversations, is incredibly important going into the rest of this year and the following year. Thank you.
Excellent. Tracy.
Yeah, I just wanted to also flag that as part of the public operating plan narrative that's included with the paper, we are using that to trial our new campaign strapline, Caring Where It Matters. And we've had some quite a lot of discussions about it. We think it talks in a number of ways. It talks to equalities and inequalities and inequity. It talks to place, but it also talks to the things that we are focusing on. So very keen to have some feedback, but that's what we've tried today in terms of a way of, it also demonstrates our compassion for people.
Very good.
So just wanted to flag that that's where we're going, subject to endorsement from partners.
So I've got one. Oh, no, you go for it.
It was just a comment really on the design of the document, trying to sort of, I think the style of it is definitely more engaging, and that front page, is a language that I felt I could read through. So I thought that was a really good sign. I think some of the flow about it, maybe needs a little bit of work. But I just wanted to, it referred to regions, which I wasn't sure whether that meant regional, because I think it meant Cornwall and the Isles are silly. So region doesn't make sense to me as a reader. But I really liked the structure and the clear programmes of transformation. I think on change programme 4, which was the one that I was particularly interested in around the prevention and long-term conditions work, it felt like it needed a bit more content, and I think there is that discussion going on, but just to sort of talk about the 3 conditions, but not talk about some really clear things around tobacco that is a priority for everyone, hypertension detection. So some more specifics in that would make sense, because otherwise it feels a little bit woolly, would be just my reflection on that particular section. And then there's the prevention box, which is on the end of page 29, which then has a lot more information in it. So perhaps just linking those 2 things from my perspective. But I like this style.
Lovely.
Thanks.
Good. Yeah, no, very good. Hayley?
Yeah, and also just on the improving access to mental health services, absolutely the right things to do. I think we've still got a job to do to get that into tangible plans.
Yeah.
Come on to that a bit later, no doubt.
Thank you. Ali?
Thanks, Chair. Yeah, I really like the look of this, and I think it's written in a way that's really easy to read, which helps me a lot. The only thing I'm really acutely aware of, and I think we've talked about this before as a system, to challenge ourselves to make sure that we've got children front and centre in some of our plans. And I think you pick it up in the vision, and then I'm not really clear how the transformation work programmes, and apologies, I've been out of the office, I've only looked at this morning, then really links back and has children really front and large in the plans around transformation. So I think we just need to challenge ourselves to make sure that we've got children and young people in there. Thanks.
Susan? Did you want to answer that?
No, absolutely agree, Ali, with you. So we can review those and put those in.
Okay. Good. Okay, thank you, Ali. So the one that I would like to pick up, and I suppose this is a question to Susan as the Chief Executive today, and Simon, noting that you said about the X-ray car. So it seems rather ironic that we invent them, the concept, take it through, and we've still only got one X-ray car and one Falls car. And we talked at the last board and the board before about how do you have one per ICA equals 6 cars. So where are we in the concept of actually escalating that in readiness for winter?
So we've been really clear the success of the X-ray car and the Falls car, and what we are planning to do specifically for this winter is to have them at either end of the county. I think for the future planning rounds that we're going through now, we would like each ICA to have Falls car and an X-ray car. That's our direction of travel.
So that's 4.
That would be, so for 4 for this year.
4 for this year.
Yeah.
Okay. All right. Progress. Simon?
Just we need to be really clear about making sure we can make the change in how we spend our money locally to free this up, to shift that activity out to the community from the acute setting.
Are we accepting that is a decision, and that's to do that from the board to go to the 4? No point having a board if we're not going to decide stuff. So
I think we need to recognise that will incur cost. So we need to understand what that cost is and make sure
we're not doing it.
Pardon?
So we're not doing it.
I think we're planning to do it. So we just need to close out that discussion with partners about.
Our next board meeting is September. It's pretty close to winter in my book. The time you get these things up and running is now not the time to decide this. Roughly 1.4 billion organisation, 2 cars, really?
I think we should be proceeding with planning. I absolutely agree with that because it is showing. My understanding is it's showing the right outputs, so it should be where we're putting our money.
Absolutely.
Absolutely what?
That's what we're planning for. But Simon's right, that the nub of the problem here is that we have to be able to shift because we can't afford on top of what we've already got. So there has to be a shift of funds, resource to be able to fund it.
Yeah. What I understand is planning, but it requires a commissioning shift, and this is not the part of the meeting where that's possible to commit to.
Okay.
Yeah.
Mary?
Yeah.
Mary?
Thank you, John. Thank you, John. I appreciate your pursuit of this. As a board member, the assurance I need is either that this is already in our operational plan and we're preparing for it, or if it's not, what are we doing to balance those things that are in if this is to be preferred? So I agree with you, John. We should be getting that assurance as to how this is going to happen.
Thank you, Mary. Neil?
Just for further assurance on another matter, at the Integrated Care Area Committee recently, the discussion revolved around the need for community-based initiatives that deliver care close to home to be featured in our integrated performance report, and the X-ray car performance was one of the things that was being picked up, that would be reported regularly to board to give assurance that things we're investing in are delivering quality care for people, one, and good value for money, and better for staff and well-being for patients.
What I'm going to suggest, I with respect, Sandra, I hear you. If this was a multi-million pound investment programme, I get it, but this is well within the scope of delegation to our chief executive. So with your support, everyone, I'd like to actually admit the fact we will ask our chief executive to have decided imminently, not before the September board meeting, as to whether we're having 2 extra or we're not.
So just for clarification, we'll as of September, we'll have 2 Falls cars. We are getting pump priming for X-ray. We then have decided that another X-ray car would be beneficial for the winter.
Okay, so we're proceeding with 4. As the chief executive, that's what you're deciding.
Yeah.
Okay, Martin?
I suppose just to say, hopefully the decision that the chief exec is going to make is backed up by the evidence and the data, i.e., we might need 4 in North Cornwall and none in West Cornwall. It's not a geography thing, is it? But, I've got no idea how the thing has worked in terms of demand, supply, travel times, whether it's better to actually have 3 out of hours rather than 4 in hours,
So it's a very good point, Martin. And what we're really clear about is part of the transformation and the priorities that we agreed as a system earlier in the year here in St Austell was for the 24/7 part of the programme, of which this falls into. So whilst we have ambitions that we've got good services wrapped around each of our ICAs, we're cognizant of the fact that within year, as Mary's pointed out, we have to be really careful about the planning and the shift and capital allocation. So we have got a longer term plan over the life course of the joint forward plan, where that modelling becomes much more refined. Because if we get the UEC element right, what we put in today, we may not need in 3 or 4 years' time. So, for example, frailty, if we're taking more frailty out of the acute trust and we're doing more upstream with primary care, some of those conditions we may find, or the way in which we treat them will change in 3 to 4 years' time. So that modelling, the constant modelling, is going to be really imperative here.
Yeah, and I'm not slowing it down. I'm agreeing with John, we need to push and get stuff done. I'm just saying let's base it, on need.
Which my understanding is absolutely evidence-based. In every committee I go to, I hear this. So why would I pursue such a small item? Think about what I said at the very introduction of the meeting. There's going to be some really big decisions that we've got to take for next year now. And if we're struggling to make a decision on 2 cars, how are we going to make the channel shift for 25-26? So these are the tough conversations that are coming. I'm sure you'll sort the cars one with the other. my real sentiment behind it was, behind that challenge was we're going to do channel shift. Best know about the scale and pace of that in October, if that's the planning plan for next year. You've got to decide what you're going to do this year.
Yeah.
And that's within your scheme of delegation. So my serious point was, are we really going to have yes, let's do the principle, but when it gets to the hard nails of channel shift, process, money, etc., we need to have had that out in October, please. Does that work for you, Simon?
Absolutely.
Yeah.
Absolutely. And
Lady, does that work for you? Yeah? Yeah, cool. And I'm sure if your colleague from RCHT was here, they probably agree. We just at least need to know the sooner rather than later. Okay. I hope I didn't deflect the journey there, but you see where I was trying to go with that. Okay, shall we move on from the chief execs? Yep.
I wanted to just briefly mention that we had our ICB annual assessment last month. It was very positive, and the outcome letter of that will be coming to the board in
Very good.
September.
Yep.
Thank you.
Lovely. Thank you very much. So we move on to updates from the committee chairs first of all. So I'm going to go around this way if I may. Sanj, first of all.
Firstly, we will come on to talk about SIP delivery, but there is a concern for me there around being behind on SIP delivery across the system, not in any one area, not least because we have to catch that up, but also set ourselves up for next year. So I'll say more about that. And then the other point is 78 and 65 week. We are off track on our numbers. We were meant to hit 0 for 78 weeks in June, and we're in the 20s. And 65 week, it doesn't look like we're going to hit that 0 by September. So that's something we're following up on with colleagues to see what needs to be done. We'll say more on SIP delivery when we get to that agenda item.
Thank you. Okay. Martin. Sorry. Neil, look down the table.
I promised to give a verbal update on the Integrated Care Area Committee. We welcomed the new place directors and welcomed the fact that they will be embedded within the system, working operationally to link with what we're hearing about here in this document, Care Close to Home. And what we heard, again, in terms of updates and reappraisal of their priorities, was the volume of work going on at place, often linked to the voluntary sector, trying to work on integrated neighbourhood teams, which is linked to proactive and preventative care on a personalised basis for patients, which is so important and fits with many of the priorities that are in the document that's been presented. As I said before, we're hoping to bring evidence of the benefits and cost improvements related to that into the IPR as we emerge through the year. And I just wanted to recommend that we do need to keep going and assuring on integrated care, but we're now at a point where it is so much part of what we're wanting to do, which has been agreed in our joint forward plan, that we will be looking to assure regularly, but have less committee meetings to allow people to work within the system and get on and get things done at place. Can I just make one mention of the Quality Committee? It says nil report in the document. It's not because it didn't happen by accident. It's now not happening other than when really needed, other than on a 2-monthly basis, because it dovetails with the work that the System Quality Committee is doing.
Very good. Thank you so much. Martin?
Yeah, no meeting this month, John.
Thank you. Nick?
Yeah, so you had system quality on the 2nd of July. I think there was I would say it's a privilege actually to chair such a unique committee. And there was a recognition of the positive work that committee is making. I think the other thing as well, we took one particular item, diabetes. And the bit that really excites me is the commitment to a medium-term financial and service strategy, which prioritises investment in community-based services and prevention work, targeted health inequalities interventions, and that will go to SEG to allow joined up system thinking. And that, for me, if we can bring that back in the next meeting, will be aligned to everything that you just said, Chair. Thank you.
I have to say, Nick, as somebody who attended the SEEK meeting, I have to say, at a partnership level for something that is quite innovative of bringing, all the clinicians of the senior providers and the ICB together with the wider group, it was a fantastic collaborative discussion that actually I thought was going to lead to something. And what it's doing now is actually going to set the scene for what the next one's going to be as well.
Absolutely, Chair. And that's the hope. If we can get it right for this particular clinical priority, we can use this template moving forward for the other clinical priorities.
Well done. It was and well chaired, by the way.
Oh, I learned from the best, John.
Tan.
In terms of PCC, we've got the dentistry update and the transforming primary care reports on the agenda, so I won't go into those, but hopefully we can engender a spirit, the same spirit of collaboration that you've managed to get in that committee, Nick, into PCCC. And in terms of workforce, the only thing that we need to note is that we need to be careful about the numbers, because the spend is drifting a bit already by month 2, even though we were reaching the numbers on the whole time equivalent. The envelope is not quite right, and we'll
financial envelope.
We'll look at that more presumably this afternoon.
Thank you very much. So I'm just going to make this observation. So on partner members, Steve and Smitesh, I'm not expecting you now at your first meeting to sort of like make any major points, but Smitesh, just as observations, is there anything you would like to add as a partner member at the moment?
Not at this point in time, thank you.
Thank you.
Chair.
Steve, on the call, is there anything that you would like to make as the Devon partner member?
No, thanks, John. But really interesting to hear the debate. And actually, I've got some things I'd like to steal from what you're doing already.
Lovely. Thank you. So stepping in for Debbie, Adi, is there anything from your seat?
Not for this session. I think we've got quite a bit in this second
Lovely.
session.
Very good. That'd be really helpful if we could maybe leave things to the things on the agenda. Ella, from?
Yeah, so provider members is in the pack. Would you like me to pull out some pertinent points, or are you happy
We're
to
going to
take
go through
it
the
as read?
IPR. So
Right, yeah, I was going to say most of the performance elements. There are some important strategic developments in there, but I know people will have read those.
lovely.
Thank you.
Thank you. Ali, anything from your seat?
I've got a few points, John, if I can, and I'll be
Yeah.
quick. But
Yeah.
I just wanted to let partners know that we're out to advert at the moment for the operational leadership team in adult social care. Last week, the ILAC inspection of children's services concluded. So we're waiting for the outcome of that, and I'll share that with colleagues when I'm in a position to do so. We've also had notice from one large privately owned care home that they're intending to close for business. So Kate's aware of that, and I will keep you informed as we progress that. Director of Public Health report focusing on work and health will be coming to a future ICB meeting, and the public health team are quite busy at the moment developing our research centre and building that capacity, working with academic partners, the voluntary sector and our communities to really get underneath the nub of what research is. Discussion on fluoridation of water was held at scrutiny yesterday. I wasn't there myself, but I understand it was a challenging debate. But the system is continuing to focus on all options to improve oral health. And then just linking to the general election, obviously we've had a significant change in MPs across Cornwall in the last week, and the council's really keen to work with the new UK government to on a whole range of initiatives, really, to try and get better outcomes for Cornwall and Cornwall's residents. Thanks, Chair.
Okay. Anything anybody else would like to add at this point that I've not turned to? No? Okay, thank you very much. So let's move on to the IPR. So Susan, can I turn to you first of all, please?
Yep, thank you, Chair. So if we just start, first of all, the IPR was validated as of May, end of May. However, I just want to note that some of you will have other information because particularly around areas like elective, things are moving fast. So this as always, is a retrospective look. So if we look at our system oversight framework, we're comparing the published position in May to March. There's been an improvement with 40% of the indicators being in the lower quartile in March to an improved position of 24% in May. The system confirmed by NHSE is that we are still in system oversight framework 3. In terms of urgent emergency care, all indicators saw a decline in position and an adverse position against trajectory, which included our 4-hour standard, the overall system performance, which includes not only our ED department, but our UTCs and our urgent treatment centres and our minor injury units. The system performance for May was down to 76.65%, which that's a downward trend from 79%. Ambulance handovers, again, we saw a decline in May to 90 minutes, which is an increased in the time from the performance seen in April, which sat at a better 64 minutes. That, of course, has an impact on our category 2 ambulance response times. The impact of April's 4-hour performance and reduced ambulance handover delays resulted in improved category performance of 40 minutes, 29 seconds. However, when we saw May's figures come out, that performance has dropped to 54 minutes and 12 seconds. We have put in place a recovery plan, and this is something that is featuring very highly at the moment with any meetings that we're doing with Region, NHS England, and indeed the national Tier 1 meeting that I did earlier last week. Our same-day emergency care activity has seen an improvement in month, closer to the target of 30%. And if you recall, our same-day emergency, we have a unit that's in Bodmin, and we are about to open the unit down in West Cornwall. Start date for that is the 22nd of July. So that's a huge step forward. And that's in part to try and take offer a choice to people to take some of the workload for people who are elderly and frail away from ED, because we know that they're the folk that end up in ED for long periods of time and are a bigger proportion of our no criteria to reside. That's our delays waiting for onward care. We know that if we can see them through the same-day emergency care, we can turn people around quicker, get them home with support, so we don't see those long stays in hospital, which we know causes debilitation, further debilitation. Our system no criteria to reside did see a reduction in the month of May, but mildly adverse to plan. I am happy to say, having looked at this month's data, we're seeing an improvement on our no criteria to reside, and really getting to grips with placements for people and working very closely with system partners, both in the community and in our local authority. The system is implementing a focused urgent emergency recovery plan with senior leadership, which we need to work at pace to realign performance with a focus on effective use of alternatives. We are setting ourselves an ambitious goal of 15 people per day through our same-day emergency care units, which doesn't sound very much, but if we have 2 SDECs, so 2 same-day emergency cares, that's 30 people that are being taken away from our emergency department. That's quite a substantial number, and when you model that through in terms of looking at things like no criteria to reside, average length of stay, even the impact on outliers, people that are not in the right wards in the hospital, a huge positive impact. So we have an awful lot of support, and we are working hard to make sure that that becomes a reality. And I have to report the feedback that we got from the people down in West Cornwall was incredibly positive around the same-day emergency care. So I think winning the hearts and minds of people to use these services, and SWAST as well, our ambulance services, are working very well with us in terms of having the confidence to reroute people away from our emergency department. So we're continuing that work, and they're part of that UEC recovery plan. Coming on to electives, Chair, 78 weeks, we have not yet eliminated. We know that they were at their highest in December 22, and we've seen a reduction in the total numbers of 78 weeks across all of our residents in Cornwall and the Isles of Scilly. The recovery trajectory is in place, but it is at risk. RCHT are focusing, and there will be 9 patients who will have exceeded 78 weeks at the end of June. I think we saw that number rise slightly. Some of that's due to tertiary referrals, so patients that are referred to other hospitals, patients who've become ill. We've seen a spike in COVID in the county, and again through patient choice. We're continuing to work with those people. We are phoning them up. They're not just being discussed as a number in a meeting, and offering as much choice as we possibly can. Our providers are clear that we are pushing for 0. However, we've not been able to make that for the end of June. The work that we've done with RCHT is really clear around how they manage their waiting list, so ensuring that there's a higher proportion, a higher percentage of people who are at 78 weeks and 65 weeks, so that the mix of the waiting list reflects not only acuity, and we know that we have to do our waiting list in chronological order, but trying to manage that is a real challenge for the trust, but they're rising to that challenge. Diagnostics rankings at the end of 24, at the end of the year, showed there were only 6 other areas with better performance than ours. So we are the second best performing trust, system, in the southwest, and we know that if we get our diagnostics right, it's a central tenet to our RTT recovery. Because people have to go through that diagnostic phase. I think the other thing to point out on the electives is our cancer faster diagnosis achieved in April, 5th consecutive month we've achieved that. 62-day performance was improved again from 73% to 80.88%. So I think we really do need to congratulate the Trust in getting there. It's been tough. But again, better outcomes for our population. In terms of mental health, despite a recovered position earlier in the year, the volume of out-of-county mental health inpatient placements has increased over recent weeks, between 15 to 20 patients at any given time. CFT continue to work on reducing the volume of patients who are ready for discharge with onward support with inpatient mental health wards in collaboration with adult social care. But as I said, these numbers are higher than we wish. We've got a meeting coming up with CFT to discuss how we bring down those numbers and how we manage them.
Thank you. So let's start in reverse order, if I may. Adi, from your perspective, anything you want to add?
Just echo what Susan's saying there. So that we're talking about May numbers here, and we know that they've increased slightly in June as well. So we're actively sitting down to just put all the information together, lance some of those old narratives, so that we've got a way to work forwards, and then how we collectively share the risk and how we collectively work out who's on point for what part of that. So no criteria to reside, also clinically ready for discharge, crisis services, and any out of hospital community services that would help to bring that down, but also modelling in some of the other work that's coming back.
Absolutely.
Yeah. And just before I bring in Ella, from Steve's perspective in Devon, and a Peninsula perspective, is there anything that you would like to share with us before I go to Steve for his observation?
Yeah, no, absolutely. So we, as Neil said earlier, we've now got all of our place directors in post, and Trifina Doyle is the place director for the North and East. So Trifina and I have sat down with Leighton, our director of delivery, to talk about the issue of no criteria to reside in Plymouth, because I know it's a much higher proportion than Plymouth would like. I've also had some conversations with Joe Beer, the Chief Operating Officer. So some of the work that we've been doing in Cornwall that's really helped the no criteria to reside hasn't been happening in Derriford. So we're putting those measures in, i.e. some of our services like STEPS, which take people out, working with our voluntary sector, our community sector, again, to bring people out of hospital. So I think being able to make sure that the work that we do in Cornwall, we're also sharing with Plymouth, is incredibly important for so that we've got that choice and better standardisation for our patients that go into Derriford.
Have anything to add?
Yeah, my hand was hovering over the raised hand, but I didn't want to spoil the flow in the room, but certainly wanted to come in on that issue. Thanks, John. Yeah, we are seeing some challenges in the UHP catchment. Really good to hear Trifina's in post. Actually, I think I know Trifina from previously. I think the numbers for UHP, it's about 20%, the no criteria to reside for South East Cornwall patients, so it is quite a significant issue. I was just going to say, John, we've changed our process around performance management within the Devon system, and I'll be chairing locality catchment meetings so that we can bring together all the various elements for, in this case, the UHP catchment, and very open invite for South East Cornwall to the ICB to come along to that, so that we can have a rounded discussion about all of the issues, both in primary community and in the hospital-based system, as we try and make improvements in that area.
Lots of nodding going on. Did you want to touch on anything, Neil, on that? No, that's very good.
I wanted to bring something up on the IPR later.
Can I just let Ella from your seat?
Yeah, so it was outlined in the providers members report, but I just wanted to draw a bit of attention to the work going on in RCHT in relation to the urgent and emergency care standard. So as Susan pointed out, really challenging month, May, and that continues into the June data, certainly. But we have, the Trust has reallocated all of its internal flow programme to focus on the front end element of that pathway. So very much with the same principles around same day where we can. So making sure optimising same day medical assessment and making sure that our medical model within RCHT is bringing up front the assessment to get patients in the right place as quickly as possible. And that's a really concerted effort in the last month in terms of all of our research being on that and trying to land some big changes in that space.
Okay, thank you. Nick and then Rachel.
Yeah, so thank you. I always enjoy the actually added colour to this because I don't think there's an answer to this, but the data being presented is always a little bit behind real time, and that's just, I think, a challenge for me as assurance, and I just want to say that out loud. But Susan and colleagues, I think the verbal update does add colour. And then I've got a really simple question is, if we're going to miss 78 weeks for elective, when are we not?
I didn't catch that, sorry.
So if we've missed 78 weeks, nobody in by the end of June, when will it be zero?
So the patients that are left, there's work going on to bring those patients forward, Nick. As I said, some of it is difficult because if it's tertiary referrals that we've made, there's not an awful lot of control that we have. And don't forget, we've also offered much further. Our tertiary centre for many of our services are UHP, but through patient choice, we've offered further afield to bring those. So we have got some challenges. I think that as we've described many times, the biggest pressure is in orthopaedics. So we've done a huge amount of work with RCHT to engage the independent sector. Unfortunately, when you refer to the independent sector, once they've gone through their assessments, they may decide not to take the individuals. So we are working through that figure to make sure that we're getting to zero, because we know that hot on the heels of that, we've got 65 weeks, and then we've got 52 weeks. And we need to get back to 40 weeks. So some of the work that we're doing with the independent sector, I suspect, will continue. We need to do that. And we also have the elective surgical hub coming online in September, which will also help.
So we have elective later on to talk about.
Yeah, no, but I just wanted to say as well is, I mean, and I would just want to recognise actually your point in the thing that you're not treating these people like numbers, you're treating them like people. And I just think it's right to recognise, and the reason for asking the question was a lot of that, if that's driven by choice, I think we should just recognise that. And I was really heartened to hear you say that. So that's why I wanted to raise the question. Thank you.
Yeah, just a couple of general points. Some of the performance indicators where we're not where we need to be are proxy measures for outcomes as well. So we talk about, for example, fractured neck of femur, not just thinking about physical health, but out of area mental health placements. And I'm just wondering if it might be helpful for those areas where there is a direct link to quality, that we have that assurance coming through, that we are monitoring that. And the second point was, I know that work's going on through QPOC, but to pull out that assurance into the IPR. And the second thing is that I think what's helpful when you look at the provider updates that are feeding into this, you do start to see where our patients, depending on where they live, have different access to some of the services. And perhaps that's a lens through which we should look at our operating plan for 25-26 and look to close some of that gap on the basis of equity.
Good. Rachel?
Thank you. I noticed that the report is focused on the quality of care, access and outcomes, and I think that they are usually in the performance report focusing on that subject. But the preventing ill health and reducing health inequalities part of the NHS oversight framework we're not looking at. So they include key metrics around treatment for diabetes, prevention of CVD, cancer screening programmes, GP uptake of various programmes. So I would ask that we might have a board meeting where we are looking at those metrics to balance out the performance report, if possible.
Let's move on. No?
I just really wanted to welcome the same-day emergency care unit in West Cornwall, and particularly in relation to the fact that I have had feedback being involved locally in Penwith that the advisory group have been glad to work with RCHT and the place director in ICA to achieve that. It's just a word of caution and an ask. Often when we transform things, we get to a point where we say, we've done it, and that's only the start. And an experience of having done exactly that before says that if we lose confidence of partners like SWAST, if we over-impact on other partners like primary care, we end up with problems emerging that stall the progress and trajectory of that work. It's just and ask that that's kept an eye on, and particularly, and I hope it will happen with the place director in place, that the links with other partners like the voluntary sector that are crucial to keeping people and care close to home and keeping people moving through the system quickly will be really part of that work. It's so much wider than just a change in who delivers a service.
Okay, thank you very much.
I just endorse Rachel's point as well, because I do think if we're talking about prevention, which is now running through all of our strategies and plans, we do need to really focus some of our IPR on that, because what gets measured gets managed and funded.
Yep. Quite right. So let's move on to Patrick. Where is Patrick? Patrick over there. Yep.
Yeah, so I'll be brief, Chair. The workforce data in the report is for month 2. This is showing the metrics that we're using to monitor progress against the operational plan for 24-25. The headlines at month 2 are that in relation to workforce numbers, whole-time equivalents across substantive, agency and bank, the trusts are on track against the operating plan, but in relation to costs, we're off track. We are making inquiries and working with trust colleagues about the mismatch between whole-time equivalent numbers, which are looking good, but costs which aren't. And we'll be bringing an update on that in the month 3 data that will go through to Workforce Committee at the end of
What's driving that?
July. We're not sure. We're still inquiring into exactly that. It could be a number of things. It could be skill mix in the workforce numbers, that those numbers that are in post are expensive roles. It could be accounting between capitalised revenue accounting that's a different cost, but that's the question we've asked the trusts and we're working that through.
So I think the question there is to ask for that data and that understanding of why we are where we are to come back to Workforce Committee at the end of this month, please.
When is that? This month, is it?
25th of July, yeah.
Ella, that's okay?
Yep. We're working on it, I think, with you already, aren't we, Patrick?
Thank you.
Anything else on workforce? Martin?
Just say, obviously, step 1 is to understand why it's there, but step 2 obviously is to correct the
do something about
the overspend as well. Right. So forget that bit.
Did we ever get an answer to the deployment of the near 3,000 whole-time equivalents?
Not in the way that you would want it, John.
Are you still asking that question?
Typically.
So I think we did, in the sense that we did a lot of work last year that explained the workforce growth and attributed it to the different reasons that came from this board. So if there's an outstanding question relating to who they were, what those roles were and what they were for, then we can take that.
So we're going to need to pick it up later under productivity, because when we get to the discussion point, which Simon, I know, will want to raise as we go through it, if we're still 19% less productive than March 2019.
That question is still live, very much so.
That has not been answered. So there's still anything else on the workforce side? No? Simon, we're in your hands.
Chair. You've got some month 2 data in the report, and worth reflecting that we were reporting on month 2 at pretty much the same time we were finalising the plan submission for this year. The reporting we've got has been slightly restructured to try and represent it in a slightly different way for this year, leading with the risks, the key risks on the financials, and then going through some of the key numbers and the key drivers that we're looking at to inform that. Hopefully that's proving a slightly more helpful structuring with more graphical stuff. And in future, we're expecting to bring forward more on capital and cash at both the local and national level. Those are very much going up the agenda, but that's for the future. In terms of the position here, I guess there's some very simple messaging, which is at month 2, we've got a position that at system level, we are reporting off track, and that's reported within the RCHT position. I would say that all organisations, I think, are experiencing the risk that was in plan at the moment, and our absolute priority has to be to now actively work together to get back on track. That's substantially around SIP in these figures, but it's also around cost control, because we've already talked about some of the stuff where actually the things that tend to cost money aren't necessarily the things that you want to be doing, whether it's out of area placements or some of those things. So we will be working together to get better assurance on what actions are in place to recover that position, to assure both this board but also NHS England that we can deliver the plan that we've all signed up to, because that risk is not only concerning in terms of financial delivery, but fundamentally, going back to your opening point, this year, next year, 5 years, we have to get this year on an even keel, and we have to have the recurrent savings at a level that they need to be, and we'll come back to that under the SIP report, because that's what underpins our ability to do the transformational change and the right things we've already talked at around the table. So that's the context. Much more work to do over the next couple of weeks to bring that back on track, in my view.
Thank you. Everybody happy to move on? Very good. Thank you. So we move on from the integrated care reports to dentistry. So I'll tell you what I'm going to do here, because I know that we've got Kirsty loitering in the wings. Yes, I can see you there. So what we're not going to do, Kirsty, is go through the paper, because you don't know us well enough to know that we take that as read. So I shall tell you what I'm going to do is I'm actually going to ask the board your views on the paper and get you to respond to them just initially, if that's okay, Kirsty. So having read the paper, and John, yourself, given the discussion that took place with the 30-odd dentists and that kind of thing, which is more live than the paper in some ways, I'd like your take on what next, as well as Kirsty's. So could I ask the board, what's your perspective on the paper? And maybe Tan, as the chair of PCC, you might want to kick off.
I think this is a starting point for us. There's some really great recommendations in there, and some good suggestions and some good action, particularly around children and targeting those children that are most in need. I think as a system, we need to recognise that we need to go further, and that there will be future movements that will be needed. This links us quite nicely to some of the EDI aspects later, I think, particularly, for example, people with learning disabilities or difficulties, the level of their dentistry and access to dentistry and their ability to be able to navigate their way through the system to be able to get dental care is at issue. I think similarly, if we looked at access for people who are homeless, and whether they're able to get equal access to care, I think there's some really big issues there that we need to address, as well as the whole general need for access to more dentistry.
The reason why I wanted to start there is, if you look at the paper, it talks about the journey of it going through. It's already been through the ICB board. There's a draft strategy. Has it gone to the executives? I'm conscious of today's date, so it could have done, the 11th. Have you actually received that strategy? Does it actually embed itself in what will actually happen as a result of that, so we can actually see and monitor what comes out of it? Because with respect, some strategies are sufficiently generic. You go, yeah, I can sign that off. But actually, does that strategy have enough detail? I'm just taken again by the meeting that we had with 30 dentists, and what was said there, and the things that they're demanding. Do this by X date, Y, etc. And I don't see it in the paper. So Kirsty, why don't you take that?
Thank you, Chair. So I would completely agree with that. I think what we need to be mindful of is, as you said very much eloquently at the start of the meeting, primary care is wider than just general practice. So actually we have an overarching, or we're drafting an overarching primary care strategy, but within that there are 4 pillars of work plans. So, and dental is one of them. And I recognise the fact that actually we've moved on quite considerably, even in the last few weeks, in regards to the paper that's been presented. So there are things that aren't mentioned in that paper that we have been made aware of within the last couple of weeks. So things like, we have identified funding to commission an additional 23,000 units of dental activity. And we've also been able to, or will be able to fund that at a rate of £35, which is more in line with what the dentists are wanting. That came out very clearly in the engagement event. And that will be rapidly commissioned over August, in order that we can try and start that from September. We've also moved forward quite considerably in regards to commissioning the dental van that the national team are pushing us to have. We already have one in across Cornwall and the Isles of Scilly, and we are utilising that to increase our dental delivery to specific cohorts of patients. So we're looking at veterans, homeless, fishermen, travellers, some of the children that come out of the oral health work that's going on with the council. So that's moved forward. We are having discussions with our contractors currently to look at those that are underperforming to see if we can rebase those contracts. The issue that we have, and we need to be really mindful of, is that we are very much still guided by the national frameworks within this. So if I give you an example, if a contractor is underperforming, I cannot automatically change their contract. So I can't remove activity from them. I have to have a mutually agreed position. So the framework nationally doesn't allow me to do that. So we do need to be mindful of the fact that we are very much guided by the national frameworks around this. We are also reviewing the potential for commissioning child-friendly practices. And I've just picked up a conversation with the regional dental officer around commissioning dedicated provision for cancer patients, because we recognise that that is a massive gap. It's a massive gap nationally, but definitely a gap across Cornwall. So we are looking at that. We're also looking at, I've already started the conversations. What came out of the engagement event was workforce. Can we do something differently? So looking at apprenticeships, salaried dental practitioners, and I've picked up those conversations and we've already instigated what does that look like and how can we take that forward. So there has been quite a lot of work even in the last couple of weeks.
Okay, thank you. And the assurance that I'm going to turn to Tan, because it says in here August PCC coming through. I think if you could work with your colleagues on the non-execs on there with the executive group to manage everyone's expectations, because Kirsty, there was 1,000 takeouts I got from that conversation with colleagues in Bodmin, and one of them was you can move it to £35, £85 kind of thing, but unless you can resolve this logjam of other things, and there's no point us having cold comfort that we've sorted this at £35 if in reality it doesn't actually get another tooth sorted. So I guess the challenge, Tan, from a scrutiny perspective is you need to apply the so what factor. It might be the plan, but if people on the ground aren't doing it, we haven't made the leap. So if you could scrutinise that in August, I'd be very grateful. So sure. Rachel wanted to go next.
Yeah, Kirsty didn't mention her exciting session with Health Adults Overview Scrutiny Commission committee yesterday, and I think she provided the update and had discussion, and I think that was very well supported in terms of the progress being made actually. And there was alongside that we had a discussion as well around fluoridation as a preventative approach, because we need to use all the tools in the toolbox in this scenario. We're talking about commissioning dentistry, but actually you have very poor oral health and children have their dental caries. A quarter of children in year 6 in Cornwall have decayed teeth, and that is much higher than national average. So we have an issue around a preventative approach around diet and toothbrushing and oral health in general. So just wanted to flag that. I think there's a long way to go on the community talking about fluoridation. But I think we also need to be aware of obviously the government context in terms of their commitment to changes around dentistry practice and contracts, and also oral health. So it's a moving feast, isn't it? And I guess we all hope that those changes are brought forward very quickly.
Okay, Ali?
Thanks, Chair. Yeah, I've got a couple of points. First of all, thank you, Kirsty, for the paper and the overview that you've provided there so far. I was really pleased to see that the contracts for urgent treatment are being extended. But I just wanted to ask you around how you're promoting awareness for the urgent treatment for dentistry, and if you've got any kind of analysis around the demand failure, because I've heard some really, really challenging stories where people with learning disabilities and or autism are waiting, insignificant dental pain for extractions. And then my second question is particularly around what are your thoughts and consideration in the strategy around the skill mix of staff, and how you might, look at dental hygienists to do some elements of work that historically have been done by dentists. And I just wondered what your views were on that. Thanks.
Kirsty?
So in regards to the kind of urgent care stuff, Ali, we have also commissioned more. So we've actually commissioned approximately 387 sessions per month from the 1st of July, which will deliver appointments for 1,985 patients per month. So significant, and I agree with you around, but we're not advertising that significantly. We need to make sure that people know they can call 111 and get access to those stabilisation and urgent care sessions. What we are finding, however, is that whilst people may attend for their urgent appointment because they're in pain, they're not following up on that in terms of enabling us to make them stable from an oral health perspective. So the purpose of the stabilisation sessions are you get fixed, but then actually we sort out your teeth so that you're going to be all right for a little while. And we've got lots of DNAs in regards to that. So there's a piece we need to do around what actually is it that people need and make sure we match that. So yes, in conversation with Lucy Tucson, our communications director, around how can we best improve that. So definitely agree, and also agree that I don't think we have been looking at how our comms needs to be amended for different cohorts of patients. It is very much been one message, and I think we do need to think about how do we feed that in better, and part of that is also the bit around, so we are commissioning some special provision in specific schools in order to enable people with learning disabilities, etc., who live in to have access to dentistry. So we are looking at how we can manage that.
Thank you very much. Emma.
Just picking up on Kirsty's point, I think there's a lot that community hubs could do, and there are dental practices in some of our community hubs. But the point I was going to make about the report, which was really helpful in terms of understanding the magnitude and volume, could we talk more in future reports around the outcomes that we're seeking to achieve by all of this work? Because there's a lot, we know there's a lot of challenging outcomes at the moment. Yeah. So it'd be nice to see more focus on what we're going to do better.
Thank you. So John, I want to just hand over to you in a second, and then I'll bring in others. Again, looking back to that session with colleagues, I think this board committed itself, given the fact that last year there was a dental underspend, that we'd never be there again. And if that's the case, Kirsty, what I'm looking for is, have we actually got a solution that will actually maximise the funding we've got now? There's no point talking about more if we actually can't spend what we've got. So in reality, I'd like some assurance that we're actually going to execute on the ground that which we commit to do. And I was particularly taken by the work of a colleague in the dental area of Lostwithiel. And you know my view on pilots. If we think this is, if they, which is what I was taken by, if colleagues in the dental community think that is the answer, where is the cohort of people writing that as a proposal to bring that back to say, this is actually part of the answer? Because that's a bottom-up solution to the problem, not a top-down one. So again, PCC Chair, if I could ask you, I've heard a lot from colleagues about the Lostwithiel experiment. Is it something you want to scale? Is it part of the strategy? Does it fit into where Kirsty's wanting to take it? You don't need to answer it now, because what we're going to do is we've got in the paper, you're bringing back a dental strategy to PCC in August. This was about more of a download, Kirsty, to get there. John, what's your view on what you heard?
Thank you, Chair. Thank you, everybody. Yeah, we know it's a really complex issue. I wasn't able to attend the engagement evening. I had a different engagement that evening, but Chris updated me. And I think Tarn's point that this is a sort of starting point. It is. We are constrained by a national framework and a change of government, which will make this a priority. One of my roles in ICB, we're sharing with Chris, is dealing with complaints, and the vast majority of complaints that we receive are dentistry. And it goes back to what Nick was saying about it's much easier to realise these aren't just numbers or a percentage of our complaints are dentistry. These are people that are really struggling day to day. Again, Rachel's discussed it, so we'll bring data on the rates of dental care.
Solutions with respect. We need you to bring back some solutions to PCC.
So the meeting that Rachel's alluded to, Kirsty has done some going to PCCC. Because, again, having an agreement on the price for dental activity is a step in the right direction. But again, if we go back to that, are we getting what we've commissioned? Is the problem.
Are you feeling assured?
I will feel more assured after August when we've had more of a space to discuss this at PCCC. And I think that's where we need to go with it. John, please.
And wants to add something.
So I'm not looking for answers today, but perhaps feeding into that August PCCC discussion is great to see the prevention work, especially with children and brushing and other areas. But at the heart of that is the sort of 1,441-day wait, and paired with that is the stabilization work to, I assume, help people manage their oral health till they can see an NHS dentist. And I appreciate there's a limit to what we can do within the national framework, to John's point. I suppose it's what coming out of the PCCC would be helpful is what is the timeline to try and improve that, even if we're talking years. But I appreciate if there was a ready solution, someone would already be doing this, and this is chronic and large, and the paper really teases out what we can do around the issue, particularly in prevention. But I think it would be good to understand what we can do about the actual access to oral health services within the NHS. Yeah.
Kirsty.
So just to assure the board, we have a £3.7 million investment plan that will be going through PCCC in August. So you will see the overview of that in terms of what we plan to deliver this year in terms of that additional investment.
Okay, Tracy.
Yeah, in terms of solutions, just going back to Rachel's point about fluoridation, when the timing's right, it'd be really important for the ICB Partnership Board to understand the impact that might have on the health of children and demand for services, but also that we get behind that if we think that's going to be the right thing to do for our population.
Okay, let's leave it there. Thank you. Just to finish off, though, Tan, from my perspective, is that for those who don't remember too much about the Lost Withiel experiment, it was quite a bold solution that actually chose to take the funds that were available and focus on children, vulnerable adults, and that kind of thing. And if ever you wanted funding being spent on the right kind of things, it doesn't have to say we have to do this across everywhere, but in the areas of deprivation and need and that kind of thing, if the Lost Withiel answer is part of the total answer, I'm trying to understand if that is what local dentists believe in. I'm not saying it is, but that's what I was hearing. Is that why aren't we scaling it? That's got to be part of our challenge, because that is within the art of the possible within the national contract, because they're actually doing it.
And John, if I may just say that there's been a certain amount of braveness in that space as well, because there was a lot of pushback that said that we couldn't actually target those different groups. And we are going there because we think it's the right thing to do. And if we need to push back up and say, we think you're wrong, we're going to push ahead in this direction, we don't think you can restrict us from doing so, then we will be brave and we will target those people.
I was hearing was they were reaching out for support from the Integrated Care Board for the kind of things that they wanted to do, as opposed to being told we can't do it. So there's an element of you need to look into that for us. Great conversation, everyone. Are you able to, Steve, you want to make a comment before we finish?
So, John, just to say we're having very similar debates around that precise issue in Devon. It may be an opportunity for us to join up on that and learn from each other. So I very much encourage, I'll get my people to get in touch with you, if that's okay, to Kirsty, so that we can think about how we might take that forward together. It's not so much a sort of safety in numbers thing, as there may be different ways of doing similar things that we can learn from each other by doing them in each of our patches.
Thank you. I'm glad you said that, because I live on the Cornwall-Devon border, so I'm very happy with that at a personal level. I'll declare an interest. Literally, the final word from Kirsty.
Just to say, we work very closely as a region on dental, because it's not just about Devon, it's about the Southwest. Work very closely with Devon. We try to make sure that we align, because whatever we do in Cornwall has an impact across the region. So yeah, absolutely happy to do that.
Thank you. In fact, I should do a shout out myself based on that. I have to say the Southwest Regional team have been fantastic in trying to find ways to support us to do this. So thank you to that team as well. So Kirsty, are you able to stay with us until 12:30?
Yes, absolutely.
Okay, I'd be really interested in your engagement on the primary care paper, if that's all right.
Yes, happy to.
Thank you. Thank you. So, colleagues, let's go to the recommendations. We note the current position. We continue to support the strategic plan as it is, but I think we're also saying let's be focused on how that lands itself in reality. That will come back to PCC in August, and a dental paper that isn't a version of what we've got now, because it doesn't fix the problem.
Yeah.
But we have something that within the national framework says we can spend what we've got in the areas where we need to spend it by September, please. All right. Thank you very much, everyone. So let's move on to the board assurance framework. So bearing in mind, Molly was going to lead on this, and literally because of her accident, it's slightly changed. So I have thrown the gauntlet to a couple of colleagues who have, that's a fastball, but so thank you for helping us here. So between Tracy and Jess, can I look to Tracy, who's in the room, please?
Okay, thank you. I think the kiosk for the board today is ahead of our August board development session, where we look at our risk appetite and the BAF in a bit more detail, is to agree that we use the strategic objectives set out in the joint forward plan as the framework for our board assurance framework. So that's the recover, improve, value and transform, which we're also using for our planning framework that we'll talk about next. So there's some work already been done in anticipation of that being supported here today to realign our strategic objectives, our risks, and align them to those new strategic objectives. So I think that will be further discussed in August, but it's important, I think, that we are refreshing early in the new year. Also set out here are the current red corporate risks, some of which are reflected in the BAF. We have 18 of those which score 15 or more at the moment. All of those are being reviewed by executives, but also importantly by committees as well, those that relate to particular committees. There is, in line with the requirements of the board, an existing BAF entry being suggested to be stood down today, which is around not having the appropriate structures and frameworks and evidence to ensure quality. Susan can provide the context for that, and a new risk descriptor with a score of 16 for a risk of excess mortality and morbidity due to weaknesses in preventative measures, service provision or access to services. I think it would be helpful to understand from John how that links to our mortality data. And then a previous risk around not maintaining compliance with changing legal, statutory and regulatory expectations is now picked up in an existing BAF entry. The only other thing I'd say is we've got a BAF entry on here with a score of 6. These are supposed to be our principal risks, which might get in the way of us delivering our strategic objectives. So I think if we've got a risk as low as that, probably needs to come off, but we can have that discussion in August. So this is really getting ourselves prepared for a more substantive discussion next month.
Very good. Any questions on this?
We want to ask Susan and John about those two particular risks, because the board have to agree those two today.
You do.
Thank you. So the work that we've been doing around quality, because I think it's been acknowledged, it's been quite fractured in the past. So bringing our quality around the new, I've got the acronym and I've now got to work out what it is, National Quality Framework, the NQB board, so that we've got a framework for which we can be really clear about our quality and our quality metrics, because I think it tends not to be as clear as it could be. So taking that work forward, we've now got Ashleen in place as the Director of Nursing. So she's taking a lead for that work so that our risks can be reviewed around quality, but also the links made, Chair, because I don't think we also, Tracy pointed out when we talk about the IPR, we do need to make those clear links between where we see our performance dipping. And I know we take that work through our QPOC, but I think we probably need to close the loop on that to make sure that we're reporting back what the outputs are.
Okay. Do you want to finish off before I hand it around to other colleagues?
No, that's fine. It's just whether John wants to say anything about the new risk.
Yeah. John?
I mean, it encompasses so much of...
Sorry, could you speak into the microphone?
Sorry, it encompasses so much of what we do. You'll see on the chart there the new system morbidity and mortality group meeting, which feeds into QPOC and SIQC. So that's where we will, it's monthly. We've had our second meeting just last week. So as part of identifying particular issues based on data across all providers, so that we've got an identification from that point of view. In terms of the excess mortality due to preventative weaknesses in preventative measures, then again, as we establish our programs of care, clinical reference groups, And as part of the Core 20 plus 5, whilst it will take a long time to come to fruition, that is the driver towards reducing inequality and equity and any excess morbidity and mortality.
Rachel?
Can I just ask if, because there's a consultation that's just been out around the NHS outcomes and oversight framework, so I didn't know if you'd responded to that, or if are there significant changes you're aware of that would then impact on this?
So I think it's been put on hold a bit because of the election. There are discussions going on at the moment, I think, about the measurability of some of the things that were proposed. So we are keeping in touch with NHSE, but that has not quite landed yet, I think. Yeah.
And as we start to get clearer on some of the Secretary of State's direction of travel across health and social care, I'm sure you'll pick that up in August because it'll be heavily trailed. So Emma and then Nick.
I didn't know whether you wanted us to hold off on suggestions and comments for August, in which case I will do that.
Oh, yes, hang on. Yeah, hang on. Yeah, do it then.
Just really a comment that I really welcome the piece of work and look forward to seeing where it goes and how it builds. I think it just gives a great level of clarity. So I just wanted it to really welcome that piece of work.
Thank you, Martin.
Yeah, just to pick up on the new risk, I must admit, reading it quickly myself, I hadn't realised that it had been expanded, if you like, from, risks more to do with sort of waiting list ambulance into the sort of broader risks of our prevention strategies not working, which I think is what we're saying is now included. I think that's a really good point. And it's great because having that here enables us then to take that risk into our committees to say, are we achieving the right things on prevention? So it brings that up our agenda, I think, both at the board and the committees, which is great.
Okay, so sorry, Neil, I couldn't see you there. Sorry.
I just wanted to raise the point around preventative measures. It's easy for us to sit and think about health type interventions, but I think it's really important when we think about excess mortality and morbidity that some of the things we're going to come up against are the wider determinants of health and are not always within control of the ICB, but more of the ICS.
I get that. So, Tracy, if I could ask you on behalf of Company Secretary, for a moment, could you make sure that each of the committees take these risks? And assuming that they've got some insight, got some meetings before the August away day, I think it'd be helpful for each of those relevant committees who've got the ownership of some of these for the chairs to actually have considered it beforehand and brought that as opposed to just rock up on the day. So I do think if you could get them to start to think about turning those reds amber and what the scrutiny challenges are. It's going to increasingly be our theme as we non-exec colleagues as we go through September, October, November, December, is gaining assurance how we turn red and not just justify the red, but start turning red into amber.
Very much so. I think where there aren't committees taking place between there and then, we'll at least get the chairs and the lead exec together to have a discussion to feed in. Better. And I think part of the thing that would be helpful in terms of the operating plan for 25-26 is for committees to have a bit of a discussion about what would it take in order to move those below a red. Right. And that would help us to try and focus some of the priorities that we need to take over the coming months.
Okay, so I'm going to move to the recommendations, if I may. I'm not going to read them out. There's 5 of them. Have a quick scan down there. Are you happy for me to say that the board is happy to support those 5 recommendations? Yeah. Yep.
To add to the committee and discussions is that it's very easy when you're looking at this to look at what's on there and comment, and the big key question is what's missing.
Yeah. Okay. Right, are you happy? You're happy with the recommendations? Definitely. Yeah. Let's stick with that. You happy with the recommendations? Yeah. Lovely. Is there something else you wanted to add as a recommendation?
No, I think that we'll pick that up in the guidance we provide to the committee.
Okay. Thank you very much. So slightly ahead of the curve. I was hoping to be slightly further, but here we go. So now we've got. Simon, you're leading on this, or is Tracy leading on it? Thank you. That's why I was hesitating. So thank you, Tracy. Over to you.
Okay, thank you. So there was an ask at a meeting a couple of months ago from John, and I think very helpfully, to get ourselves ahead of the game in terms of I think initially the discussion was around the financial plan for next year. I think in discussion at execs, we felt very strongly that we can't really deliver the financial plan without having the wider operating plan that sits behind that. So we've set ourselves the task of getting a draft operating plan in place by the end of September to be reported back to the board beginning of October, and then to have a full operating plan. I mean, the intention is with contracts signed off by the end of March. That is perhaps a bit challenging, but I think that should be our aim. Of course, there will be further work to do on the back of the expectations and requirements of the new government around health that we'll need to take into account. But I think we're already getting a clear sense of direction, which is completely in line with the things that we've set out for our 24-25 plan. So the process that we've set out is included in the papers. I think the fact we're starting much earlier allows us much greater lead-in time to prepare for the proposed changes, both in terms of channel shift, SIP delivery and so on. And I think we're having a planning workshop with our partners next week. And one of the things we're doing is lessons learned from this planning round. And of course, some of the challenges we have is that some of the work we did around, for example, evaluation of winter and picking those schemes up was post 1st of April. And this process will allow us to have all of that in the contracts for the year ahead. So we're really looking forward to continue the direction we've already taken, building on the things that Susan talked about that we're doing in year to ensure we're moving more specialties into communities, investing more in prevention, consolidating general practice at place and primary care more generally, and taking forward the plans developed this year for respiratory, cardiovascular and diabetes. And I think that talks to one of the points Rachel made about the lack of specificity this year around those items, because the clinical reference groups are in the process of deciding the priorities at the moment. So we've got a set of planning principles which are based entirely on our integrated care strategy and joint forward plan, and build on the strategic direction set by at our True North event. We're taking that life course event, and under the ICB partnership board, we agreed to set up 3 life course steering groups: Start Well, Live Well and Age Well, which are just about to kick off now. We've got people at the centre receiving personalised care, focusing on prevention and place-based. So looking at what we need to do once, what we need to do 3 times, and what we need to do more at a local level. We've got a shared set of principles that all the working groups and technical groups will work to, and all of this has been signed off at SEG from an executive perspective from all sister partners before coming here. So as I've said in the last item, we're looking to the framework, focusing on recovery, improving value and transformation, as used in this year's plan that was part of the Chief Exec update. I think it's important to say we're building on quite a lot that we have already done. We're not starting from scratch. And one of the things we'll be doing at the planning meeting next week is to set out all of the things we've already got in place, some of which will need refreshing. So as a system, we are building what we've already done. In parallel, we'll need to be reflecting on what's happening in year. So where we start to move off pace on year, if we don't get back on track, that's going to have a direct correlation on what we can do next year. It's really important that we are doing what we can. And I think actually some of the difficult discussions we'll need to have this in year around how we do secure that channel shift to move some of the things around that will support the schemes that Susan talked about, will set the principles for how we do that for next year. So we will have to do that at pace. So we will be looking for earlier mobilisation, building the changes into contracts from the beginning of the year. We will have those working groups which are linked to our programme of care work, and we'll be meeting the programme of care leads at lunchtime, supported by a number of technical groups. So we'll have one around activity and finance, activity and performance, one around system workforce planning, one around financial planning. I think we may have one around estates as well. That will be something we come, if we're going to start moving services, we'll need to think about the estate requirements. Digital may be another one we need to do, but bearing in mind the discussions this morning, and we've talked about one which is much more around demographics and population health. So if we move to the principles, what we have done...
Can I get just people to comment on it?
Yeah, sure. Yeah. Okay, I'll be very quick. Yeah, what we've done in the principles is to give a bit more detail so we understand what we mean around channel shift, and it's much, as we said this morning, much broader than just around moving services out into the community. So the workshop next week will look at learning lessons from this year's planning round, planning assumptions, building on what we have in place, the big ticket items for both system and individual organisations, because where we've got big things going on in organisations, they need to be aligned with, supported by and informing what we do at a system level and the top risks for each organisation, which will feed into the event we had earlier. What you had in your packs was the planning that got us to the October meeting, and what you've now got on your tables is the plan for the remainder of the year, which will get to a full plan by the end of March. We are also going to, at the event, talk about the assumptions. So, for example, we might be talking about one of our financial assumptions being flat cash for acute providers, but we'll need to be really clear what that means. And we'll need to take into account, obviously, the work coming out of the government. We've got a gateway going back to SEG at the end of each month leading up to what we're doing. And we've provided on the last page the work we're asking of the system working groups under each of those 3 banners of improving value, transformation of care. So, for example, KPIs specifically around what that work will do to, for example, reduce demand for acute beds, reduce workforce costs, for example, and a bit more detail about the system technical groups that will support it. So we are trying to take a very triangulated view to coming up with something that's rounded but informed by our experience in this year.
Very much. So, colleagues, I just want to make an observation because I want to make a recommendation so I just sort of set the scene, if I may. Part of the journey that we've been going on was to make sure that by the time we got to September, October, we would actually have out there some aspirations for 25-26. The timeline takes us to September, actually, if you look at it on Appendix 3. So I just want to be really clear about everyone's expectations, because half of this is about managing everyone's expectations and pace and that kind of thing. So sometimes people see the lens and see it from their lens. Well, you need one lens, right? So my understanding of this, which is what I'm going to be suggesting is recommendation 4 on top of the 3 that are there, is that all this great work that will take us through to September, thank you for summarising that, but then for 6 months, every board meeting like a metronome from October, Simon, the first meeting in October sets the scene for 25-26, not a high level, here are just the key principles, because as we talked earlier on, you can have the key principles, but when you get down into the weeds, it says we want to move 20 million from A to B. And suddenly the person benefiting it from it actually says, I'm up for it. The person losing it actually says, I'm not. Should we start that conversation in October? Yeah. So what I'm looking for, not the answer now, but I'm looking for us to agree that there will be, like a metronome, in October, in November, in December, in January, February and March, you will come back as a collective group, because it's not just about the 2 trusts and the ICB, to be fair. This is channel shifting. It's about the whole way this is going to work at community, etc. It probably will control the 1.4 billion, but the implications of the shift around could be very significant. And I'd like to know whether we're up for that in October or how far we are from that in October. Is that a fair question to ask?
So we will have our outline commissioning attention set out then. What we've done with what we've tabled now is set out for the remainder of the 6 months. What we can bring back then month on month, we'll set out what we expect to bring to you every month between October and March. And actually what we're doing at the planning group, which AD and Ella are part of, is week on week saying what did we deliver last month, what we do on track for the next week.
Was that the additional bit of paper?
It is, yeah.
I missed it. Has everyone got the additional bit of paper?
Yeah.
Okay.
Just so you know, we've got the plan beyond October.
I made my notes before we got here. All right. Okay. So we're going to Tara and then Emma.
I'd really like to welcome this and direction of travel. I think this is taking us on a journey that we agreed, particularly in March and April, that said at the moment there are aspects of our system that are broken. And that the trajectory doesn't improve unless we do something different. Yep. We can't just tinker around the edges. This isn't about agreeing a budget in March and April and then coming back a year later and looking at it. So I think it's really important that we all sign up to those principles, that actually we will be able to look at what has changed and what will change. As an observation, what I see that we do within the system is we're quite good at agreeing to the top lines But then when it actually gets to change, we find that very difficult. We're good for new investment, but we're not necessarily good at being able to disinvest in the areas that will be required in this process to be able to invest in the change that we want to see. So I'd like to see everybody committing to this journey, really.
And the language of cutting is quite different from reworking, from redeploying, from refocusing. So we just need to be careful that change doesn't equal stop. It might do it differently.
Agnostic.
Emma and then Rachel.
I just wanted to commend Tracy and the team on the appendix. I think that it's the first time I've seen something so clearly setting out what it is we need to do over the years. And as somebody who sits outside of the NHS governance, this is so incredibly helpful. So thank you very much. The question I've got, and particularly in relation to next week's planning meeting, but actually our metronome over the course of the next few months, is where place primary care and the voluntary sector in those discussions, because we can't set commissioning intentions for channel shift and change if they're not.
Part of the reason why I wanted the agenda to read the way it did is, in a second we'll be talking about primary care in its wider sense that is linked into that, and therefore that will all be part of the financial planning exercise that will challenge us with, if we're genuinely going to buy into the next couple of papers, the implications of that are do something different of a scale. And we just need, what it also means, and I'm looking to Ella from your seat in that going forward, is what that means is that if we did agree in October, all the teams have got 6 months notice to actually say, I've got to do, not in year, but I've actually got ready for next year. So it's not a question of I can't do it this year, it needs to be the year after. With 6 months notice, it's well ahead of the curve. So we're going to go Sanj and then...
Okay. Thanks. Really helpful to have it laid out, Tracy. A couple of questions. One very low level is, why are some of the things on slide 8 greyed out? Because they're quite important, certainly for me, productivity level assumptions, but also the language has changed around place-based from the one I have written here to the one there. It says assess scope for place-based delivery, which for me feels a bit woolly, but it's then been woollied a bit further in my view to start to assess scope for place-based delivery. And it's essential that we get that into the timeline here. Otherwise, it's not going to happen. But also, in fairness to other providers, if there's a channel shift going to occur, they need to know about it in a timely way. The other thing is just the joining up of things like the work of the clinical reference groups on transformation doesn't really square with the way the groups are organised on the last slide. And I'm just wondering, where does that take place? Because you've got the system working groups, you've got the 3 proposed system technical groups, but for example, the transformation associated with clinical reference groups, where does that work happen? Because that's quite key to doing channel shift and person-centered and some of the design principles you talk about at the start. Thanks.
Yeah, really good point. So bringing together both your points and yours, the place directors are going to be really important in terms of ensuring that place element is absolutely crucial. So the meeting we're having last week, all the place directors will be there and they'll have a key responsibility in ensuring what we're doing is, and actually the default position should be we're doing it locally unless there's a good reason it needs to be done. So as I said, we'll be talking about what needs to be done once, what needs to be done 3 times and what needs to be done at a more local level. Most of the work that the clinical reference group's doing is feeding into one of those 6 groups with long-term conditions. So we've specifically talked about respiratory, cardiovascular and diabetes, and they will all feed into that long-term conditions work. They are due to report in August in order that they can be informing what comes back to this board in October.
Very good. Thank you. So we're going to go Rachel, Neil, Adi.
I'll be quick. In principle, should we include net zero and the green plans for our NHS? Because just a principle that we're not really discussing, but just for consideration. Yeah. And then secondly, I think that Ali in the past has offered to have discussions with the finance directors in terms of aligning the financial planning and just obviously I'm doing that on behalf of Ali, who's I think there, but in terms of the council and the interface. So that was number 2. And then thirdly, I've been here long enough to know that if you have a system operational plan, but you have separate organisational operating plans, and I know a lot of this is about aligning that, the change might not be able to be made. So the trusts do have to have their own operational plans. So they have to speak to each other.
Okay, brief.
Okay, really briefly, sustainability is one of the principles on our slide, and that's one of the issues we'll be talking about next week.
It doesn't come across as net zero, it comes across as financial sustainability. If
we will be really clear about that because that's the intention, and our sustainability lead will be there.
So can we also issue the dates for the November and early New Year away days? Because we have agreed as a group, the away day in November is going to be a digital one, and the early one in the new year is going to be an estates-based one. And in estates, for me, Rachel, that's actually got to have the net zero element within that.
And also delivering the green plan through some of our clinical services as well, which we're doing quite well on.
That'll give us enough time, if we do that in January, February, before we get to the March window, to have gone, yeah, we were tokenistic, or no, we were actually serious about it.
And just going back to Rachel's other point, the fact we're doing this earlier allows us to align with the council's planning framework, and we've got that on the agenda for another meeting next week.
Again, just before I bring in Neil and AD, I just want to say again, these plans, Rachel, they need to be just as much focused as in year, because there's implications to decide what are we going to decide this year that actually impacts next year. Then there's next year, but we can't forget there's things that we're doing now that might not pop out until 5 years. So we do need to be in the context of that, but we're going to go to Neil, AD and Nick and Emma.
Thanks. So, yeah, picking up your phrase about scope for delivery at place, there is delivery at place. It's further delivery at place that we really need to hear about, and that being right across the system. Delighted to see on page 10, place directors will lead the discussion at each working group on the scope for delivery at place. At the ICA committee, we talked about the need as we go forward into the next year to assure on the progress of channel shift, or, when necessary, to not assure. So that we will be looking at how this is working. In our discussions, we talked about business intelligence. John, you mentioned AI, Brave AI at the beginning. Some of the ICAs are already using that as a tool. And we talked, and we've had board meetings that have looked at population health management tools and how different parts of the system can use those and look at different lenses in different ways. In order to join up these working groups, we're going to have to agree the population health management approach that's for the system. One other point, business intelligence, workforce finance, 3 proposed system technical groups. I hope there will be major cross cover and people working on behalf of those working groups to work within those technical groups, because the issue of business intelligence to look at issues at place is something that is lacking, but there is no lack of facility of business intelligence within the whole system. We're just not necessarily joining it up in the right way to look at the things we really need to look at. So please, it's a plea that to underpin the working groups and give the intelligence that's needed, we don't go cap in hand hoping that one part of the system will help another part. Let's make it work. Let's look at what we've got available and make it work for the system.
Here we go, colleagues. So here's what we're going to do, because I really want to stick to time, if that's all right. So we're going to go AD, Nick, Emma and Simon, and then I'm afraid we're going to pause, summarise it and move on. So AD.
So I welcome the definition, so actually we've done this before, haven't we? Given ourselves some priorities and then all gone off and decided what the priorities mean to each of us, and they're different. So the defining of that, I think the next step is the definition behind these. So what are the outputs?
Cool.
Because the grey areas are just starting something. So we've started it, but what's the point? At what point in time do we get an output, and what point in time do we all sign up to? Exactly, that's it. So we can take those things forwards. Timeline-wise as well, I think doing it for September, October will actually fall in with Ali's timeline for, I think there's a Christmas time. So.
Tracy, that isn't on admin control, is it?
It may not have gone on there yet, but we circulated it last time.
Other formal board papers, would you make sure that's added? Thank you very much. Nick?
Yeah, really briefly, Chair. So really welcome this conversation. I'm going to sound like a broken metronome, but on the working groups, primary care is wider than GP practice. Thanks.
Okay. Noted. Emma?
I'm reassured about the input of place and primary care. I'm not so reassured about the input of VCSE in the planning process. So I think we still need to agree that.
Pick that up. Thank you. Noted. Thank you. Now, Simon, finish us off.
Yeah, so I think for me, this is an opportunity to shift things the right way around. we talked about maturity of the organisation and the system. We've almost focused heavily on the financial balance stuff, and we've been playing catch up to some extent and having to have aspiration that turns into plan. This time we have to have plans articulated, wrapped around those CRG works, so that what we are doing is reflecting in the finance of the activity the firm plans that everyone's signed up to. It removes any chance for confusion and means that we can really measure progress.
It's a beautiful, beautiful summary. Thank you. So I'm going to move us to the recommendations. I think just before I get to them, I think if you think about some of the things again I said at the very start of it, we're going to have to make some tough choices, colleagues, as we go through this window. And I'd much rather be in a space in October where there were clarity of options without the ambiguity of, well, my interpretation is this, taking Adie's point, or my interpretation is that. I'd rather have clarity, so as if we could all agree, wouldn't it be lovely? I'm not sure we will all agree in October, but isn't that the joy of starting it in October? Such that we can say, well, what does that mean for November, for December, etc. But the harder that you can be on pushing it to the, what's the pinch point of what does it mean for this area has a consequence on that area, and does that area sign up to that because of the benefits from the first decision? The sooner we get collective decision on that, the sooner we can say, let's crack on with it, and that's a done deal for next year. So that's the principle behind this, is trying to get collective decision earlier on channel shift, our numbers, our budgets and activities and outcomes for people. Does that work for you, Tracy? Yeah. Okay, so let's move. I'm going to add therefore my fourth recommendation. So the first one is agreeing the guiding principles. I think they're fantastic. If you can just add that to the board pack.
Yeah, we'll do.
Thank you very much. Affirm that the joint forward plan objectives and the framework for development as in Appendix 2. I think we'll agree that. I think we're more than noting, I think we're violently agreeing with the, I hope we are, with the timeline that you've added. Now you've added that one that takes us through to the end of the year. But I would like to add the fourth one with your support, which is just an explicit thing that we're going to start from October to actually not have just the base principles out here, but some flesh on the bones that teases out the distance that we may have yet to try and close as a group of people, as a unitary board, between October, every month coming through until March. Everyone happy with that? Yeah? Yeah? Very good. Thank you very much, everyone. So that's that one. So how about that? We're bang on schedule. So now, 10 minutes on SIP. We could spend a lot longer on SIP. Okay. All right. So why don't you, rather than walk us through the detail, we've read it. What are your key themes and what are your asks of the board?
So I think this plays back to the conversation earlier about having not just a plan, but a deliverable plan. We've got the month 2 position where at system level, we've got RCHT reporting off plan that links their overspend position at month 2. ICB were looking at slightly behind plan, partly around CHC. CFT was slightly ahead of plan, but we also know that the expectations ramp up in the later part of the year, both in terms of profile and some of the issues like the transformation savings that cut in the later part of the year. The crux of this for me is getting back to delivery and to assurance of future delivery, not just on the in-year. Going back to your point on the recurrent, now, I don't know if Ella may choose to say something, the recurrent delivery significantly below at month 2, and I think there's something about how RCHT are reporting some of their savings in there. We have to get that rectified, and we have to be able to clearly articulate against the work streams that we've agreed, workforce, etc., how all of those sums are tracking through. We'll pick up some of this as CFOs tomorrow morning when we meet face to face. But fundamentally, over the next 2 to 3 weeks, we need to get back to an assurance position about this year's delivery with confidence on all of the CIP. Yes, other cost control, but fundamentally the CIP and the recurrent CIP. Have we got the plans? Have we eliminated the unidentified? Can we report back on that confidently? Can we see the risk profile, which was high when we submitted plan, steadily coming down? And our test should be that coming down and down over the year. I don't think we're there yet, and the initial figures aren't telling us that. And so for me, there's an urgent piece of work over the next 2 to 3 weeks to pull that together to be able to assure ourselves and NHS England, who obviously have seen our month 2 position, that we can recover this and we will deliver in line with the plan that we signed off. Just to remind ourselves, we were one of a relatively small group of systems that signed up to delivering break even this year straight off. And if we do that, it dramatically changes our capital and revenue position going forward by £7 million. It's really important.
So can I turn to the FMP chair? What's your thoughts?
Yeah, I think we've seen the benefits from the break even we achieved in the last year, and also that particularly the audit report highlighted the scale of challenge that we're signing up to this year is on a different level. And so that's what we're coming up against in terms of struggling to achieve this. The Deloitte work also highlighted that recurrent SIPs is also going to be the hardest to do. So all of this is coming to pass. We need to work on changing the narrative. My concern is that not only are we starting to fall behind, and that therefore changes the quantum of delivery for the remainder of the year, i.e. playing catch up, but looking alongside the work Tracy is leading into 25-26, we need to create the movement and the space on SIP delivery for 25-26. So that adds on to also playing catch up on where we're not necessarily delivering. There's also a point that if you look at the breakdown of SIP delivery, the biggest area of concern is around workforce. And my concern is how joined up are we between finance colleagues and workforce colleagues around delivery, because workforce is, as we know, and has been highlighted by Margaret and others in previous meetings of this board, it takes time. There's a lead time because there's people we're talking about. And so if we're not having those conversations together between finance and workforce now, we're not going to get there in this financial year, and therefore and that is the biggest chunk, particularly on recurrence. So I'd be really interested to see what we can be doing more joined up, both between NEMs of the various committees, but also within this room with people working on workforce and people working on finance. Thank you.
It was a great opportunity that when SEEK started, because it was the quality committee, I think it was a tad of a shame that we never, through national and government issues, weren't able to get our FMP committee off the ground. But just taking your lead on, I'm just wondering whether we don't need to do this formally. I'm just wondering whether having some informal dialogue raised now, so whether committee chairs chatting to each other, getting the same message, being consistent. There's something here about temperature checking and, just checking either. Is that your understanding? Is that my understanding, kind of thing? And everybody's up for that kind of approach. I will encourage, if it's all right, Ella and Adi, particularly looking at you, if it's all right with you, I just think it would be a good idea for us all to be on the same page.
Yeah, that sounds really sensible, because we are in it together in that regard, and the financial position is one of those areas where we formally have that risk share. So it's absolutely imperative we're shoulder to shoulder in our approach. But just to reiterate, it is incredibly challenging. We knew it would be. I can speak now from an RCHT perspective. Obviously, role here today is wider than that, so I know as well CFT are doing similar level of focus as we are on this, but there is an awful lot of time and energy this week going into financial recovery plans. So not just saying, okay, we need to deliver the SIP plan, which we do, but also saying, how do we stem some of what cost avoidance can we do whilst we get up to speed on those SIP plans. A workshop happening with our care groups today on that, and us internally considering what our special measures type support will be to our own teams in the early months, so that it doesn't run away with us throughout the year.
Thank you. Mary.
Yeah, thank you, John, and reiterate really what Ella is saying, just to give the board assurance that I know all of our committee chairs are meeting on a regular basis, and this is high on the agenda. At RCHT, in addition to what Ella's just said, we also have presentations from our CDs at our next board meeting on the 1st of August. So I think this is a matter that we should start describing. It's a little bit the EDI agenda, isn't it? This is everybody's business. It's not SIP savings. This is everybody's business around how can we do differently? What can we not spend money on? But for me, and I absolutely agree with what's been said already, we are needing in year to look at radical shifting next year in order to get the benefits that we need to see, because we won't be able to realise them otherwise. So that's work that needs to start this year, and to give the board assurance, I know is starting.
Thank you. So what we're going to do, Simon, if it's all right with you, I think what I'm hearing is with Mary's and Adie's and Ella's support is on your idea, Snaj, is if you just informally start to build further relationships with opposite numbers, and Neil, you could do the same, and Tanya, you do the same. I think there's some value as we go through this journey of just everyone having a similar lens, because we're all in this together, and having one group cited that's slightly out of adjunct to somebody else doesn't really help when it comes to visioning. Adie, did you want to have a final word?
I was just going to say, in terms of not just in terms of across the similar disciplines, but bringing those three together. So, finance part is not only just the end part, ticking it off. It's happened. Thank you very much. You know, workforce enabled, the operational. You know, the operational side of things are the things that really actually get the SIP going.
Yeah.
And you've got to kind of link all three together.
Yeah.
I
think the strength is actually having us getting collective assurance. I think that's got to be the strength of going through the next few months. Okay, so Sam, I'm going to take us to the recommendations, if that's all right. I'm so excited I turned the page over, I've lost my place now. So the recommendations, to note the SIP update and the commitment to develop enhanced SIP monitoring. As we go through, I think everyone can sign up to that, but we're also sort of saying, let's build these informal networks further. And you will come back every month with an update on here. Okay, colleagues? Perfect timing. Thank you. So, can I welcome some colleagues to the discussion I've invited for the next paper? Get myself together. Right, transforming primary care and the Fuller report. So, we have on the screen Stuart. Welcome, Stuart. We have Emma, who you're with us normally, Emma, but please, as always, feel free to be as vocal as you kindly are normally. Kirsty, we're going to do this slightly differently because the way we do this here is to not present the paper and have the discussion. So what I already know is this has prompted a lot of debate. So what I'm going to do to kick off is I'm going to start to ask the non-exec directors as to their perspective on the paper, and then we'll more widely open this up. So I'm actually going to go first of all to Neil, if that's all right. Neil, what's your take on the paper? It's where it's got to. Is it dealing with the crunchy issues? Have we considered everything? What's working well in it? Where are the shortfalls? Because we want a paper back in September or October. What's your assessment of the paper?
Thank you, Chair. The first thing to say is that, as Nick has reminded us a number of times today, the term primary care is a wide encompassing term, and this paper, to an extent, covers general practice as we know it. Having said that, general practice as it's known has changed a great deal in the last few years and is much broader in its scope than it used to be, and encompasses other roles, working with integrated neighbourhood teams, and demands on general practitioners to underpin primary and community care as we are talking about in terms of channel shift. So for me, I welcomed it as a reality check, because I think it's important that the board know that whilst the performance in national metrics looking good for Cornwall compared with other parts of the country, that is at a cost to the health and well-being of people working in primary care. And it is vital that if we want to take on channel shift, health creation, personalised care, all the things that the board, I don't know whether I should stop, what the board are regarding as vital to the way that we shift things for our people, we understand that the resilience attached to primary care is something that needs to be recognised. It's a reality check. It's saying things are being done well. There has been a growth in people at the primary care base, but those are mainly in additional roles, not in partners. And it's often partners in primary care who bear the brunt of the innovative new work that's needed to link them with neighbourhood teams, voluntary sector colleagues and others. So for me, it's about a reality check. This is where we are. And if we want to see this underpin the way we want to go forward, we need to recognise that there is a need for recognition and support of what primary care, as we describe it in general practice, is doing. And we need to broaden out strategically the debate to the wider primary and community care sphere.
Thank you. So we're going to turn to the chair of the Primary Care Commissioning Committee, Carl Talm.
So I think we need to recognise that the majority of people's day-to-day interactions with our healthcare are in their communities in that primary care setting. So we haven't widened this out to include all the different elements that we need to look at. We know that this is a first step along that journey. So I support the recommendations that, as they're stated, but we do need to develop wider collaboration in this space. There needs to be more opportunities for involvement. There will be a fuller discussion at the next PCC meeting, but also in the September one, which is more focused in this space, to come back to October board.
Very good. Thank you. Nick, now I know you're slightly conflicted, but
I am, yeah,
declare your interest and then make the comment you want to.
So thank you, Chair. So, I believe declarations of interest and conflicts of interest may be slightly different. So obviously the reason I'm an ordinary member, not a full non-exec, is I do have things that I do within other primary care provider space, such as pharmacy. So having been somebody that was, and I pre-emphasised my comment on actually, I really welcome this, to Neil and Tarn's point, as a really, really good first step. Being fortunate enough to have been in two of the working groups on the fuller stock take, both on workforce and physical access and estates. This is a paper which transforms general practice. This isn't a paper that transforms primary care. Claire's definition of primary care is anywhere you don't need a referral to, which is general practice, dentistry, optometry, pharmacy, UTC and ED. However, having said that, I think this is a really, really, really important first step, and I absolutely endorse and welcome the direction of travel. And I'm under no illusion how difficult general practice is, and they should be absolutely supported by us and the board to make some of these changes happen. I will struggle with some of the recommendations, Chair. So, one, confirming the strategic intent as general practice first, that's great. Two, commitment to fairer funding. Is that general practice? Is that primary care? I think it needs more detail, and then there are some other things in there which I will struggle with. But I say all of those things with an absolute clear and determined resolve to support general practice, because they're under a huge amount of pressure. Thank you, Chair.
Okay, and before I invite, did you want to add anything, Martin, or not?
Yeah, well, I mean, we had a really good discussion on this paper actually at the PCC, and changed it a bit before it came to the board, thanks to Tan and others. But I think for me, it was, if you think about a strategy that was trying to create, we'd have where are we now and what are the current issues, which the paper's quite good at, and then what's our vision for the future and sort of how do we get there, with a bit more detail in the early years. And I still haven't quite got my head around what that future vision is, for the GP part of primary care, let alone the wider part of primary care. So I think we still need to, address that and say, look, this is where we're trying to get to. Here's our short-term things we're going to do now to try and start that process off, and here's the sort of medium-term things we're going to work on that are going to take longer. So that's what I'll be looking for to come back at the next stage, I think.
Very good. So before I bring in Stuart and Emma, I'm going to again refer back to something I said at the very start of the meeting. So this, and we had a discussion during the SIP agenda item. Agreeing to the principle, I think, could be really easy. Why would you not want to go in this direction of travel? But actually, if this actually comes with a channel shift that requires resources shift, financial shift, etc., of a scale, and there's no more money, until we know there's more money, then we have to work on, this is under our own air cover. If there's no more money, then this is a classic example, Simon, for October, where if you get into the point where we say we want to do something of scale of X millions of pounds that supports primary care in its wider sense and community, Emma, in its wider sense, and there's no more money, it doesn't take a genius to work out. That has to come from somewhere else. And there aren't many somewhere elses in our system, Ella and Hayley. All right. So it's the kind of thing where the sooner we front up to, are we serious? Are we behind it? How much in year 1? How much in year 2? How much in year 3? And what are the consequences of that based on the evidence that we have found to actually drive this? Then I think to have those sorts of things out, Tracy, in October will be really helpful to be able to say, how close are we to genuinely going in this direction of travel? I do think it's interesting that the Secretary of State's first meeting with the NHS Chief Executive wasn't in the shiny hospital. And if you want to take any signals, I think we've got to work out quite what we plan to do. We were doing this anyway, by the way, but how we turn the language of support into what does the material resource channel shift actually mean, Martin, your point, is the issue I've got. So let me hand over to Stuart first. Stuart, what's your assessment of the paper?
Thanks, John, and sort of welcome everybody else's comments as well. I think, and a key comment there really that this is a general practice paper. Really, it's not really a primary care paper, and it's very important to differentiate between the two terms. I'll just get a bit of sort of history and background on our consultation with this. So the initial draft done by Kirsty and Paula and colleagues was we were consulted on in the GP Collaborative. That was a number of weeks ago. Didn't actually get to see this paper until Monday, and therefore haven't really had time to consult. Well, we haven't had time to consult widely with GP Collaborative or LMC colleagues. So my views are very much sort of my own and those which I think represent the Collaborative Board, but important to realise the timeframes in terms of consultation have been very, very tight. I think look, the principles of the paper, I don't think we can, there isn't anything too contentious in there at all from my perspective. And I think actually if you go down to table 2.4 and the mitigations, actually the Collaborative Board are actively working on most of those points already. And certainly by October, we'd have a lot more detail on them. We have got a very good track record of working collaboratively with our primary care commissioning team in Cornish general practice, and I think between now and October we can put more meat on the bones of those issues. Just looking at them in terms of timeframes and acknowledging your last point there, John. Really the big ticket in-year spending item are the primary care hubs, and I think the rest is a lot around long-term visions. It does depend on national policy to some extent as well, or to a large extent. But in terms of what we have the ability to make decisions on, to spend money on, I think it's those primary care hubs, and that business case is fully is fully worked up. It is there. They are successful. We're seeing more recruitment. We're seeing more appointments being coming out of those hubs. So I think if you're looking for the sort of pressing spending commitments, really that's the main one, and of course that one is the one that we hope has most of effect on winter as well. Certainly by October, I would hope that the paper and the work streams are very much in line with the Collaborative Board work streams, and I would hope to have a lot more detail for them. Again, acknowledging these are my views and not the views of the wider GP Collaborative. And I think, I'm sure Emma will elaborate as well. There's some very sensitive issues around at the moment in terms of general practice and potential industrial action. And that makes, it does sort of slightly or significantly affect the sort of LMC's potential position on this. I won't go any further on that and perhaps hand over to Emma to elaborate. So, I mean, I think, as I say, if we're going to summarise, not much time for consultation, unfortunately. Broadly speaking, in line with the Collaborative Board's direction of travel, more detail required on a lot of the mitigating factors, but certainly the business case and decision on the primary care hubs is needed as quickly as possible.
Before we move on, where is that, Susan, at the moment, the decision on that?
So we're taking that through currently the Transformation Delivery Board and working with finance on it. It's exactly the same conversation that we've had around the X-ray car, the right care car. So what our intention is to continue with the GP hubs. It's understanding where they need to be, how they fit and how they are fitting with all of the other resources we're putting into community, UTCs, the SDEX, for example, and more importantly, how many do we need? And that's the modelling that we're working through that delivery programme board.
Simon, I'm sensitive to the earlier conversation, all right? Okay. But that's why I teased it out then. Is when do you think that decision, with a capital D, will be made on this?
You have to make that decision within the next 4 to 8 weeks in a sustainable way, because we need to know where we're going into winter. We need to know what our future model is, not just for this year, but for the future, and how that rolls around with primary care in general.
I'm going to turn to, I'm sorry I'm putting you on the spot today as Molly's not here, but maybe between you, me and Jess, we can get the answers. Is this decision within the scheme of delegation of the Chief Executive? I don't know how big the number is.
I think the individual decisions would be, it's a cumulative effect of making.
Yeah. Can you give me a rough scale?
Yeah.
I'd have to check. So I think we would, I doubt it's wholly within the Chief Exec's own.
Right. So
commit to it going.
Are you having an FMP between now and September?
Yeah. Yeah.
Okay. Could I convince the board that what we do is we delegate that decision down to FMP to take, so that we don't have to wait until September? Yeah. Everybody happy with that? So we could minute that. I'd be very great. It's a good decision. Okay. Okay. Stuart, you've got your hand's still up. Is that a legacy hand?
No, I just wanted to say, please come. I impress on the board to engage with the collaborative board on the decisions around the primary care hubs, or on the detail around the primary care hubs. There's an awful lot of work that's gone into that via our task and finish groups. So it's just a plea, really.
Yeah. And who will do that, Susan? Who will engage?
So at the moment, our programme director, Stuart, is Jo Cadman. So she's working with, it was Rob White, who was her SRO for that work.
Still is Rob White, yeah.
And it's still Rob White. So Jo will be working with Rob White, and we've got
Jo will impress to do that. Okay. So Emma, could I ask and invite your view on this, please?
Yes, thanks, John, and everyone. I guess, again, building on what's been said and not wishing to repeat. So speaking to your point, John, about the gap between the principle and the practice, I think it's fair to say there's been quite a bit of activity since Monday between myself and other LMC colleagues and the collaborative board in Stuart, but not the collaborative board more widely for reasons we've already heard. I think there's broad agreement with the sentiment of the paper. That I don't think is at issue at all. The detail does need to be worked through at a collaborative board level, where we sit, where our colleagues at the CIC sit as a provider, and where Stuart and other CDs are in the mix. Really important that we have that strong Cornish model. Just to pick up the point about the fuller stocktake and things that have already been said, the fuller stocktake is a paper about transforming general practice. It's not the only paper about transforming general practice. And I think this paper also, the paper in front of the board today, needs to be viewed through what has already been alluded to, which is the lens of the potential of upcoming collective action and the strong prospect of industrial action in the months ahead if negotiation with the new government is unsuccessful. Now, it has started with promise. However, we have many roads to travel before we get to a clearer picture. The LMC is hosting a GPC webinar this evening for general practice, which is the first of 2 meetings we've got this month, with a view to clarity about what the 1st of August will look like. So that we have committed to share as much of as possible, so that nobody is wrong-footed, that we understand what the principles and the concerns are. It is quite difficult at the moment to comment more widely on this paper, but I think what we have all committed to, certainly in the conversations we've had over the past few days, including a number of key people, is that we are committed to putting time and effort into putting that flesh on all of those bones, really. And I hope that is helpful. As I say, apologies, I can't be more explicit on the detail at the moment.
Thank you. I think it would be churlish of me not to invite Jan, who's actually a member of the public today, but as you're part of this journey, why don't you give us your perspective?
Oh, sorry, yes. Oh, yep, I'll have that. Thank you. I'm about to announce a train. Right, okay, thank you very much. The collaboration board is made up of 3 main memberships. So one membership is the clinical directors of the PCNs, the second part is the LMC, and the third part is Kerno Health. So there's 3 core organisations there. So when we talk collaboration board, you'll engage with all 3 of us at the same time, really. Our journey on this is we'd seen the original paper through the collaboration board, but not seen the revised at all. Stuart shared that with us. We're in support of the broad details that are there. You know, also accept primary care is wider. From ourselves, it's important that the strategies that are put together by us as an organisation who deliver at scale both in primary and urgent care actually come together and are truly supportive. So we're working one way together, and that's why I've dropped Tracy a note about the planning sessions to make sure that we're part of that reviewing going forward. Again, we support that. Same as Emma, there are more documents out there than full of stock take. But for us, it's about how we as providers, that's ourselves, CFT, RCHT, VCSEs, all come together as provision and work integrated for the best utilisation of funding for the delivery of primary care. And there's lots of different ways we can do that. And we're already lined up because of the possible industrial action that if there is anything that comes from that that needs delivering at scale in the future, obviously there'll be a process around that, but we're having discussions to make sure it doesn't disappear.
Right, thank you. So I'm going to open up to the floor. Any other observations before I can conclude? Emma?
I think it's really important for this board to have the paper on primary care and general practice in particular, and it's great to see a reference to health creation and greater integration with VCSE delivery and support. That's going to require GPs, I think, to let go of some of their work and trust wider partners, and we've got some great examples of where that's working really well, but I think we're going to need to do that more broadly across the board. But it really strengthens for me again the need for the discussions around primary care transformation to be absolutely aligned and in conjunction with the conversations around channel shift and VCFE work. At the moment, it feels very much like they're being done in separate silos, and I think we need to bring those together quite urgently.
Okay, so Anna?
Be quick, John. I was really interested, Nick, in your definition. No, it's not your definition. The definition you quoted around primary care, and that including ED, because I haven't actually heard it described in that way, but it makes a lot of sense. So I just think we should explore that a bit in the strategy and what that means around how we it's that whole urgent care piece, isn't it? And I think also just a bit of an offer really, because I noted and was encouraged by the aligning secondary care specialist neighbourhood teams. And as that strategy develops, you know, obviously a proportion of the secondary care colleagues are in our patch, so I'd be really up for engaging in the development of that strategy and that strand of it.
Bill, last word.
I'd really welcome that as an approach, having seen this from both sides of being a GP and now looking at the wider system. I think this is a point of opportunity. I really do. And I think it's a point of opportunity to change the way that people access and gain what they really need in the place they need it. And therefore, I think that doesn't just... So I think it's a challenge, not just for general practice and the ICB, it's for the whole of the system. And that's not just in resource in finance, it's in resource in people and where they actually sit and align. And I think there are opportunities to take certain aspects of what have always been deemed secondary care to become truly primary care at place. That's people and specialist nurses and teams of people who might work with general practice and all the other sectors to really provide a different model of care for our people.
Thank you. So just before I go to Rachel, Smitesh, I'm going to come to you, ask your view in a second. So Rachel?
Yeah, just a plea to include public health as a commissioner of primary care services, both dental, pharmacy, GP, and also the funder of some of our preventative services in that discussion. Thanks.
Very good, thank you. Smitesh, what's your views?
Thanks, Chair. So
Yeah, looking at the paper, I think it is. I agree with most of the things that people have said. I think it is a great first step. It's a great foundation. There are some excellent things in there that, as Stuart alluded to and Emma alluded to, that as a primary care collaborative, part of which I sit on, as you all know, that they are working towards looking at those kind of strands and strategies there. And I think there's some really good foundation there, but there is some meat on the bones required, and certainly that's something that I will take into consideration when discussing this moving forward. I think some of the great things that are already being showcased there are the hubs, and some great collaborative work there that's being done with the help of with the CIC, and some really good examples of bringing some of that specialty into areas where it's needed, as Neil alluded to, was having specialists out in the community to provide the care where patients really need it.
Okay, thank you. So, can I just pose this question then? This is more of a general practice document than primary care. I think what we need to do is have something that is a solution that supports primary care, and as part of that, general practice. So where I'm going to go on this, and I'm going to just feel like I'm banging the same drum again, but Nitesh, with your help and support and other colleagues, and through Primary Care Commissioning Committee, Tan, we need to get to October, and I'll just bring it back to September in a second, but we need to get to October where, if the ask of this is, do you know what, it doesn't require any more resources, it's just within our gift to rework this at a local level, to work with the third sector, etc. Update us. We can sort of say, fantastic, please press on with our support. If, however, what you want to do, I'm not making any political points here, by the way, or what's going on in terms of negotiations, etc. I'm trying to say, regardless of that, what would we do in a steady state? If we want to have channel shift, as we call that, which is to move from, for example, from the back door down to place level, if that works, and it works of scale, by definition, there should be less people rocking up into Trelisk. And if that's the case, that would support a channel shift of resources. If that's something that everybody wants to do and buys into and has a resource implication, we need to have that out in October. And if everyone's up for it, we can celebrate the movement, and Simon can say, thank you, I'll bag that and move on. And if there isn't, of a scale or a direction of travel, and there's a disagreement, let's get that out in October of a scale that makes everybody go, I'm actually not just doing another pilot, all right? You know my rather rude joke about we've got more pilots than British Airways, all right? So not just another pilot. How do we move on to something of scale that in the first year makes a material step in this direction, that we can look then to our 5-year plan that says, actually, this is just the first major step in supporting primary care and community services over a 5-year window. Is that something that you'd feel comfortable minuting, everyone?
Yes.
Yeah? So, Tracy, if you could help minute that language. On that basis, Tracy, can I look to you just to help me from a governance perspective? On the 6 recommendations here, shall I just sort of say, we're not going to agree those at the moment because we'd rather have a paper back in the future, and we just note them rather than agree them? Would that be happy from a governance perspective? Would you be happy with that?
Well, what we've just agreed is an action.
Yeah. So if everyone, what I'm going to do then is basically note the recommendations, but say the real recommendation is to bring something back through all the collaborative groups, because there's the collaborative GP group, but we just talked about pharmacy, optometry, dentistry, the wider third sector. There's a whole church of people that need to be brought into where we're going, and then a paper that culminates in a first serious draft in October. Through PCC, please, and FNP. Okay? Lovely. So that takes us, gosh, I'm 2 minutes over. We'll work harder next time. Okay, so here's what we're going to do, colleagues. So this is a public session, so we're going to pause the public session now. Jan, I don't mind if you want to hang on in here, but if our colleague in the corner, who's a member of the public, wouldn't mind just stepping out. if those who are on the call could just quickly move from this Teams link to the part 2 link. By the time you get back on, I'll have invited our wider colleagues into the room, and we're just going to stand and introduce each other, if that's all right. Is that all right, everyone? Thank you very much. And we'll be back at 1:30. Right, so we're now in second half, part 1. For those, apologies for being late, but we took the opportunity to meet with some of the new staff, and I have to say it was a wow moment for me. I hope you felt the same. Lots of great people there, real commitment, and lots of talent. So, okay, so let's move on. So we're now, if I'm right, we're on equality, diversity, inclusion. Patrick.
Me, thank you. Thanks, Chair. So if you bear with me, I'm going to give you a little overview of context and content of the paper that's in the pack. There's quite a lot of detail and some specific recommendations, but I thought before I even get into that, there's 3 things that I'd really want to land at board about this agenda. First of which is that internal EDI and external health equity are both sides of the same coin. And as we take this work forward, it needs to be through those 2 lenses. So I'm not here talking about purely workforce EDI agenda. It's about the impacts we have on the population. The second key bit I wanted to land is that how we take the work forward is as important as what it is we do. And the reason for that is, and we heard from Roger Klein in a development session back in June in this forum, about how so much of this agenda is about power and the relative power of different groups. And who is included and excluded from decision making is what this agenda is all about. So when it comes to defining who it is who's going to shape what happens in this work as we go forward, we've got to pay really close attention to whose voices are being heard. And work that in a different way. And then the third bit is the opportunity, which I'll come on to, which is this work we can take forward as one system. But it feels to me that this hasn't got the complications of commercial relationships and money between organisations, that there's a real opportunity to agree some common ways of working on that. So that being said, you can test whether I reinforce those principles later and then tell me in discussion whether you agree with them. As I say, the report follows on a conversation that we had with Roger Klein. Roger is the co-author of a report called Too Hot to Handle that people may well have seen. It's getting quite a bit of publicity. And that session highlighted, firstly, the established evidence that says the benefits to patient care, organisational effectiveness, staff engagement of building inclusive and non-discriminatory working environments. That session was also quite direct in saying that despite years of policies and procedures, the Too Hot to Handle report is highlighting some really challenging examples of ongoing systemic racism in the NHS. It's pretty clear and sets them out very, very clearly. Whatever approach we take to our statutory duties, the regulatory framework, the action plans that we might commit to, unless those are making a tangible difference to the actual lived experience of people who work for us or people who are on the end of our services, then we'll just be repeating past mistakes around this agenda. Roger was very clear on that. Another point he made was that over-reliance on individuals raising concerns in our systems is not going to be sufficient because of the power imbalance I mentioned earlier. If somebody has to go against the grain in speaking up, raising an issue, they're much less likely to. And the Too Hot to Handle report highlights examples of where people have almost given up raising concerns because they just don't think they're going to be taken seriously. So the opportunity we've got is to create an environment which combats some of that kind of legacy position. Since that session that we had in June, we had a discussion at Workforce Committee on the 27th on the core contents of the reports in front of you. And we also there was a regional session yesterday hosted by the regional leadership team of ICB chairs and chief execs, which was a whole day focused on the EDI agenda. So we can expect to see a lot more focus on that coming forward. And John and Tan were in attendance and may want to say a few words about that when I've finished this intro. It was that discussion, I think, that really brought home this point about health equity being two sides of the same coin with internal EDI. And what it also prompted was thoughts that how much do we have dashboards about the population impact of the way in which we're providing services and how we might develop those as a way of highlighting equality, diversity and inclusion issues for our workforce. The other point I wanted to make as well was I consulted Roger on this draft report. Said we're taking this. Any comments? And he only had one. But the bit he really wanted to push back on or encourage was that we see the EDI agenda as a means of service improvement rather than fulfilling its own purpose, which is of course valuable, but see it as having that positive impact. So the report recommends a few things. There's a bit of housekeeping is underplaying it, but there's a few managerial things we need to do off the report. So there's a reminder in there about our statutory duties and the regulatory frameworks that we are required to comply with. And those are quite complex, so it's worth pointing those out. There's also a summary of the work that already goes on across trusts and in the ICB. And it's really important that we're not starting this agenda. It's building on a lot of good work that happens through the staff networks and through the forums that already exist. In terms of the two main recommendations, the first is that this board adopt the equality objectives for 2024 to 2028 that are specified in the report. Those have been developed through the networks, the equality networks that exist across the trusts, and those have been approved through the trust's individual governance. So the invitation for us is to kind of join that and adopt those objectives. Second substantive recommendation is about how we then move on to work together to develop a strategy for achieving those. Those are very high level four-year objectives, and there's an awful lot of work and opportunity that we can be taking forward to do that. This is where we would be joining forces with colleagues across the trusts to be taking that work forward in terms of tangible deliverables that we would want to define through that. This is where I want to emphasise that how we have the dialogue and how we increase our collective understanding of what it's like to be an excluded member of our workforce or an excluded member of our population, that is the intervention. Those conversations in and of themselves will encourage the type of change that we are looking to make. So how we devise that strategy is absolutely critical. The other recommendations, there's one which is for the ICB to publish its equality information report, which is attached as an appendix to the main report. One of the things that we can be doing in the strategy work is making sure that as NHS organisations, we are auditing and assessing our position against the 6 high impact actions that are part of the NHS's national plan for this. So those are the key things that we would want to use to take this work forward. There's 3 other things I just wanted to mention before closing. The Debate at Workforce Committee raised the issue of scope. So I've mentioned quite deliberately that we've spoken about the NHS organisations, and that's partly because the focus of the national agenda for the NHS organisations is in this area. But what we were really clear about in the Workforce Committee debate is as this work unfolds and is taken forward, it will naturally play into partners across the system. And I think that would be entirely appropriate. Indeed, the NHS has probably got a lot to learn from other sectors in this area. And certainly as we develop the health equity piece, of course, that brings in all system partners. there's a key part that we would be keeping an eye on in terms of how we develop that. Make sure the NHS organisations are meeting their requirements, but take opportunities to broaden that debate as much as we can. The second part to mention is the regional work that will be coming forward. Quite challenging sessions, I think, yesterday. I'll leave John and Tan to comment. But what I took away from that is there is going to be greater emphasis. The quote was, oh yeah, we've lost our way on this agenda a bit in the last couple of years, which was quite an interesting and frank admission from regional colleagues. So we can expect there to be more focus on that. And then the final thing, and I'll invite Susan to say a couple of words, is that an example of the two sides of the same coin issue is the Women's Health Hub. So we took the opportunity in this report to provide a little bit of an update on the work that's happening there. So Susan, if you wanted to say a couple of words about that, and then John and Tan about the event yesterday, and then open up for comments and discussion. Thank you.
Well, thank you, Patrick. So you'll be aware the Women's Health Strategy was published in August 2022 with a 10-year timeframe for delivery. And with that came some money, albeit not a huge amount of money, but a significant sum of money for us to decide what we felt our priorities were, building on the existing work already. So the women's hubs that are going into Cornwall, and many of them already exist, we've decided to go for a hub and spoke model, mostly virtual, that are digitally enabled, but also using existing estates as well, bearing in mind the money's not going to buy us property. And it's very clear in what it's going to focus, the women's hubs are going to focus on around women's health, on whilst it's over the life course of girls and women. We are looking at contraception, we are looking at menopause, but we're not there, the women's hubs are not there to replace existing services, there to support, enhance those. And we know that there's a whole body of research out there, and I'll try not to get on my hobby horse, of how women are treated in health, particularly young women, and how they're often sent away. Things are put down to anxiety, hormones, and women are not always investigated in the same way as men would be. And we know a lot of research historically has used men as subjects and not women. So therefore, many of the drugs that have been developed haven't always been aimed at some of the issues that women encounter, particularly in certain stages of life, like menopause. So the Women's Hub, this is the first huge step forward, and we unfortunately had to reschedule the strategy day due to some significant individuals not being able to make it, but really excited. There's a fantastic set of slides that I have to thank Laura Wheeler, who works for Kerno Health, has included in this pack, that describes what women's health hubs are, what they're not, and what we plan to do going forward in the future, but really exciting. Thank you, Patrick.
Okay, should we chunk it up into two elements? Any comments on the women's hub? Can we park until we've just finished the first element of it, first of all? So Tom, why don't you give your reflections of the last couple of days?
Reflections, but also just a revelation, a bit of challenge and understanding, and an ask, if I may. So a revelation. I'm going to out myself now, not in the way you might think, but some of you might not know that I'm a Chelsea fan. Okay? It sounds a bit flippant, but actually this is about identity and about what matters to us. And sometimes that association is difficult for me because of the huge racism that went on the terraces in the 1980s. Okay? But actually it is part of my identity. So I want us to think about what matters to us and what matters to our community and the relationships that we make there. So Patrick and I want to invite anyone who wants to join our fantasy football league teams to come in and join, because it is about connection and about how we make things. Right, that silliness aside, okay? What I said earlier about there is no quality without equity is absolutely paramount. This isn't about equality of access. This is about equity of outcome. And it is not okay that in some parts of our county, people live 12 years longer than they do in other parts. Okay? This is the third decade of the 21st century. That is not okay. And we have to all share that. And I think we all do. But what we've got to do is move from kind of motherhood and apple pie statements that say this isn't good enough to actually how we're going to get there. So we're going to have the EDI strategy coming through Workforce Committee. Not because EDI is a workforce issue, but because EDI is a window in workforce. Our workforce are a window to our wider community. And if our staff are feeling that they can't raise complaints, then how do our vulnerable people that are using our services feel? Yeah, there's been some good action, but we need much, 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 much more in terms of being able to get some different. We need to address the equity issue. This isn't a delegatable target. This is all of our business. We need collaborative working. We need a new way of working across our whole piece. We'll get the timelines and stuff that Patrick's talked about. We'll get the actions. But what we need to move from is a system where we are looking at condition management and what's wrong with people. And we cannot have this approach in EDI. We can't just start looking at protected characteristics and what's wrong with people. Yeah? We need to look at what matters to people. We need to understand prevention and predictability with people, because traumas go in cycles and they repeat, and the same families go through the same processes. A lot of our prevention should be about predictability, about the life outcomes that people will have if we do nothing about it. So if we do nothing about it, it's on our bad that there's more people turning up into our health system. So we need a new approach, and that has to accept that the status quo is not okay. We have to tackle the power, challenge that power, particularly within decision making. We need a new compassionate approach that's about non-judgmental approaches that invest in people and their power to change their health and well-being. And that needs to underpin our whole intent. So my ask is that you come on the journey with us. None of us have got it all right. It's not a destination, but it's a different way of working and a lifelong journey.
Patrick, you invited me to give my views, but yes, I thought it was an excellent window of time being facilitated by a well-seasoned facilitator in this space, which provoked quite a lot of challenge. I think one of the things which I'd like to just pick up on in terms of this paper that Patrick is, and it's the kind of things which, when we got whittled down to just the chairs and chief executives yesterday, it got a little bit sharper, shall I say. Just being committed to promoting, we are committed to fulfilling. That's cheap. You can have that in a bat of an eyelid. How it manifests itself, how we actually get that to land and of scale. And Susan, we were talking about giving some information back to the National Guardians on freedom to speak up. Mm-hmm. There's something here for me about Roger Klein's paper left me with quite a few thoughts, but the one I want to share here is staff are leaving in droves because they're not actually being heard. We're not acting on it. We're not acting on it quickly enough, and we're not being fair enough in that. So my challenge, Patrick, back to you and to us is, I think we're all over promoting and commending. What we now need are some discernible actions. And I know I got slightly to one side of the group yesterday where a lot of cultural points were made yesterday, and I was probably one of the more in the let's do it now kind of category. So I sat next to an Asian lady, and she and I swapped a couple of stories, which I'll just share with you. But all the culture in the world didn't change the culture in China of binding young girls' feet. It actually did take a bit of central direction, and then culture began to change. So that was one example. Another example we shared was everybody wanted their own plastic bags to take their Tesco shopping home. Everybody knew how bad single plastics were. Nobody shifted. All know the impact. There's a central decision. That's going to change. Everybody moaned for a fortnight, and everybody now buys their own bag. The point being made is, at what point do we have to move beyond just saying this is a cultural problem? And at what point do we have it both cultural and elements of key decision-making that says, these will be the things that we'll put in place that will facilitate a new journey? And I don't think we're anywhere near knowing what those decisions are. That was my challenge. And Ella and Adi, there's no point us just cracking this for 300 ICB staff. There's another example where there's 12,000 plus staff in the NHS. And if you took outside in terms of the wider side of that, it's even bigger. how do we work at a level where we represent 12,000 plus staff, not just 300? And I think, Patrick, my takeaway for you is, please can you work with colleagues to find a way of cracking all those questions? Thank you. Throw it up to everybody else. Emma, sorry, I didn't see. No, can't hear you yet.
Can you hear me?
Yes.
Yeah, lovely. There's a little bit of a delay. People are definitely trying to meet me. I swear it. First of all, something really practical. I think Marie is trying to join part 2 meeting. She keeps clicking on, so I don't know if Pete can have a look at that for us. The couple of things. One relates to the Women's Health Hub work, and it's a question for Susan, really specifically. This is a really important conversation that I think started, and certainly we were cited on in terms of input by general practice as part of that wider primary care discussion. Is there something, Susan, separately that you could possibly share about how we got to the hub and spoke model? Because I think we've lost sight of it a little bit. That would be really helpful, and apologies if it's somewhere and I've just missed it, because it's clearly excellent work, but it would be good to understand where the general practice element of that has come. And the other thing is, and I've mentioned it before, I hold the role, and I've the honour, and it's a difficult role to have the Freedom to Speak Up Guardian for Primary Care, specifically for general practice in the county, and I am aware that I'm one of many Freedom to Speak Up Guardian colleagues in the region. So it would be really just an offer again, if there are things that we can do and join up. I think we'd all be keen to help in aligning what we do and how we can make sure that we help as much as we can as being part of that sort of cultural shift, really.
Take that on board. Thank you. Ali's next.
Thanks, Chair. Thanks, Patrick, for this. I'm sure you have. I just wanted to, I've got a few points if I can. So I wanted to first check in whether we were doing any work with council colleagues. You'll know that council has an EDI strategy. We had a peer review about 18 months ago around EDI, and I think there's a real opportunity for us to work together to drive improvements in the outcomes that Tom was absolutely right in highlighting to us. The other thing I just wanted to touch on is that Cornish people were granted minority status back in 2014, and I wondered if we were thinking about that and how we were sort of capturing that. I wanted to highlight to you that we're doing some work from the council with Welsh Government around 4 particular areas under our Celtic collaboration agreement, and one of those areas is around heritage and language. So I wondered, and obviously I used a little bit of Cornish earlier, and we had Steve with a bit of Welsh, and I just wondered what your thoughts were around that. Then just 2 other points: the staff forums and your disability forum. I didn't see physical disabilities there, which I thought from a workforce perspective would have been probably quite a significant number of staff. And then the last point for me is page 22. There is there's a chart that shows us the numbers of applicants and appointments per age category, and I was a little bit confused because a number of them seem to have a lot more appointments than people that actually applied in that age category, and I was like, that I'm sure it's fine, but it looks a bit odd that you're appointing more people in a particular age category than are actually applying for jobs. So I just thought I'd pick that up. Thanks.
Take that offline and go back to Ali afterwards, if you'd be so kind.
Thank you.
Thank you. Let's move on to Steve.
Yeah, thanks, John. Yeah, I just wanted to add my voice to the experience we had yesterday. I think it was a really interesting day, and there was some real passion and some, if not disagreement, then some passionate differences in position, I think, and people really spending some time reflecting, which I think is important for us at our level. I guess there were many take-home messages for me yesterday, but one of them was that we spend a lot of time finding ever more sophisticated ways of asking people from different backgrounds how they feel, are they being treated fairly, and so on. And I think the report, and certainly some of the conversation yesterday, was actually we need to spend an equal amount of time on those people who need to understand, listen, and do something about it, so that people aren't constantly retelling their story. I think was was one of the reflections yesterday. So there is something about what we do within all of our systems, as you say, many thousands of staff, to ensure that we have that sort of that competence and that understanding and that ability and space to be able to respond to these things, because some of them are very, very deep rooted, as we know.
Thank you. So I'm just conscious of time, so I'm going to ask Susan if you could offline go back to Emma on the Women's Hub one. That would be really helpful. And Patrick, in terms of the recommendations, given the debate you've just heard, do you want to reflect on any of those before we conclude?
I think the recommendations mean that there are immediate things we can do, just that we have to do, which are fine. I think the bigger recommendation is opening up the dialogue to answer the sort of challenge that you were inviting, which is what would be the symbolic or centralised actions we can take that would make a difference. A couple occurred to me through this meeting, and I'm a bit hesitant about saying these because they may well be unacceptable. But we had the conversation about channel shift earlier and our planning assumptions for next year, and we have a really clear commitment to moving resources from one part of our system to another to place. But we could make choices about which places, because I suspect we could draw on a map without even thinking about it the places where the health inequities that Tom was talking about are most apparent. So we could be thinking about planning assumptions that says we'll move more of our resources into those areas than necessarily others to test. The other category might be core 20+5 and looking at how we spend across those categories as opposed to others. But food for thought, but we'll obviously take that offline.
Thank you, Emma.
I have the benefit of being fresh off Black Voices Cornwall anti-racism training earlier in this week, which was incredibly insightful and incredibly emotional. And I think something that the board would really benefit from. It was grounded in the Cornish experience as well. And the thing that came through most strongly is that it's great to be thinking about the things that we can change in terms of our workforce and our processes, but inherently the NHS is inherently racist, it's inherently disablist, it's inherently all the isms, because it was created by white men who are very well educated, and actually some of this stuff is systemic cultural change. So the example that the person gave to me was taking his daughter to the doctor and hearing somebody say, how long does it take the child's skin to go pink? Clearly it's not going to go pink because it wasn't pink in the first place. So it's not just about thinking about our policies and our processes, it's how are we going to tackle, and I know that's not something that we can do necessarily from a Cornwall perspective, but how are we going to tackle some of those really deep-seated inherent systemic challenges that mean people of different population groups experience vastly different outcomes and experiences of the NHS and care service? And I don't have an answer for that.
No.
But I think it's worth considering.
It was emotional in the last couple of days too, and reflecting on where we've been, where we're at, and in individual status. I guess the one thing that also came from me from some colleagues who have the lived experience that we're talking about was, particularly after what they referred to as the George Floyd moment, is things haven't changed. So I think one of the things that I was just quite a protagonist on, which is at what point do we stop the academic conversation and just make some challenge, which is why the Chinese feet came up and the bag kind of thing. What is it going to take for us to say, do you know, it might not be right, but let's demonstrate to every member of staff we're serious about this and we're trying to do something of substance. And that's where I come back to do strategies that say commit to promoting. And anyway, please finish off.
Yeah, I just wanted to say the other thing that came out of Roger's discussion with us last time was that the importance of leadership role modelling and exposure to some of the examples that Emma's just provided and that we heard yesterday, because they do make you think differently and they probably make you act differently as a consequence. So I just wanted to say that in the report as well, there will be opportunities coming out of this work that will be inviting members of this board and members of executive teams to be undertaking particular awareness training or collaborations, involvement in the staff network groups where some of these first-hand experiences are had, because I think that will be important.
Thank you. So we really are going to draw a line over Mary and then Sanj, and then we are going to have to move on, I'm afraid. So Mary.
Thank you very much, John. I'll be very brief. Just want to support everything that Emma has said. And there's 2 points that I want to make. One is that there are people in all of our organisations now hearing us make these statements, but actually still experiencing everyday discrimination.
Absolutely.
Today. And I just think we've got to be careful not to be too celebratory about what we're doing when actually some of our colleagues are feeling that things are completely not right. The other thing to say is I think we just need to take some action. And so building on what you said, Emma, the APGAR score, which is for all new babies, testing on for new babies, is about whether you've got pink skin. Now, it seems to me, as an ICB board, excuse me, sorry, that we could actually say now, could we just make a different APGAR score? We could do that now. And I know our medical directors will have a view, and I'd be really interested to hear yours, John. But it just seems that is so discriminatory. And these things are symbolic. They matter, but they're also a bit symbolic to our colleagues. So 2 things, John, and thank you for giving me the space.
And Mary, as often you and I are on the same page, there's something here about doing things at scale, but also doing things symbolically, such that people believe things are going to change. And that's one of the challenges we've laid down to Patrick and the team, which is don't be tokenistic, but let's do something of scale and quick that gives people the belief that we're genuine about it. Last comment, please.
Yeah, I think it's because this is such an emotive issue. There's a risk, and I think there's a risk with us that we try to bite off more than we can chew around EDI. We can't say no to anything because it suggests we're against that area of work. And it feels like there's a lot here and it's hard to deliver. I would prefer us to focus on maybe the top 3 areas where surveys have shown we are most efficient, have the most impact on people who work for us and who experience services through us, with an active plan for delivery within a time frame. That doesn't mean we don't care about the rest, but sometimes the moral weight of responsibility means we try to have lots of spinning plates and none of them advance. And I've had experience of that. And already in this conversation, we've suggested even new ideas. There's a great blog worth reading, I'll forward on BMJ, which also sort of talks about the fact that, you know, boards are encouraged to create plans, traffic lights, and see the numbers, leaving the experience of staff and patients unchanged, too often substituting performative interventions and the abdication of responsibility to staff groups and individuals. And I think we have to own this, and therefore the accountability up to this level, but have a fewer set of things that we are definitely going to achieve by a certain point, rather than try and do it all at the same time.
I'm going to just offer the opportunity. I know we're really running over, and I'm going to really try and shut this down in a second. But Ella, and from your NHS provider's perspective, and Eddie, from your mental health one, would you back us coming up with a shorter grip of things?
I think that's really helpful, and something that in my other role on a board we've struggled with as well, the scale of the challenge and trying to do too much at once and never quite landing any of it. So I'd really welcome that guidance and prompt from you. I also think it strikes me as an area that we as a system, it should just be one approach as a system. I don't know why we would need an EDI, RCH, EDI, approach at CFT that's different to this. So can we join it up? Would be my plea as well.
Everybody up for that?
Yeah.
Well said, thank you. And we're going to minute that, and let's do that. Adi, anything you want to add?
Totally agree.
Lovely.
Connected.
I like that's concise. Agree. Thank you. Tracy.
Totally agree with Sanj that actually, if we try and spread ourselves too thinly, we don't have the same impact. Yep. And going back to that, that our strapline this morning about where it matters, it doesn't mean that everything else doesn't matter, but it means we have to prioritise in order to deliver impact. And it goes back to also to the point that Ali was making this morning, that we'd had the same debate about internally about us not really focusing on children and young people in our plan. And that's because the things that we've focused on this year are frailty and end of life. Now, we've been really clear in that end of life is for all age groups, but I think there's always a danger we're trying to try and do everything at once. And this year we focused on a few particular things, and we decided not to then add everything else in because you lose the focus of what our priorities are. So I think it's impact. A few years ago, we had a strategic plan with 10 priorities. We asked the leads to go away and say, what does that mean for our protected characteristics? And they came back with a whole range of tailored services they wouldn't have thought about before.
Cool. Patrick, what we're going to do with the board's support, we're going to capture Ellie's point and summary. We need to capture all the points that were made. I think if it's all right, we'll note the recommendations that are on here and ask you to come back again.
I would ask that there are particular things that we have to do. So we need to publish our ICB Equality Information Report.
Yes. What do you need? What do you need from us then? What
Just to say, please go ahead and publish the Equalities Information Report. It's in here.
Yep.
It's ready to go.
Everybody happy?
Yes.
Done? Yes. Anything else you need from us?
No. The one thing I would highlight as well is the 6 high impact actions that the NHS require us to do. There are deadlines attached to those.
Okay.
So we will undertake that piece of work. We have to do that.
Okay, so thank you. Shall we move on? So neatly, the next item is forward plan. Patrick, when are you coming back with
that? We need to have a conversation about who decides what the high impact 3 things might be.
Right.
So I beg a bit of time to have those conversations and bring something back.
Okay. Forward plan, colleagues, can I reach out and say, can we leave that to the 3 chief executives primarily, with input then from all the other partners as to what they would like to see? And if you go through Kate for anything you want, I mean, it'll be for me to sort of set the agenda, but in terms of, if you look at today's, I hope you feel there's a reason why they're all on there, as opposed to just here's an idea. So we'll move on from that. Jess, I haven't had any public questions this morning, so I assume we're still in that space. Is there anyone from the public that would like to ask a question? No? In which case, thank you so much for this morning's board meeting. Pete, if we could close part 1 now, that would be great.